Dr. Abed Sino. He is the UM Division Director, newly appointed. And we'll start off with updates in endometrial cancer.
Very happy everyone's here. Happy to be giving this talk. The goal of this is to try to give you this is clearly a very savvy audience. And so my goal for this talk is not to do a resident level literature review of endometrial cancer. My goal for this talk is giving just what's happened in the last year in updates in endometrial cancer. So looking at the newest and latest data in endometrial cancer. So I put this here just in case, because I always put my contact information on the last slide, just like every other person. But for some reason, I always just skip over it and leave. And it was like, no one ever gets a chance to get my contact. So I just put it in the beginning so I remember to say, you guys are always welcome to call me. You're always welcome to email me. If there's ever anything I can help with academically, clinically, whatever it is, we feel like this is part of our extended family here. You guys are a natural extension of us. We are a natural extension of you. So if there's ever anything that we can help with at UM, with any of you folk, please don't ever hesitate to reach out. So, your desktop is currently shared. Okay, how do I... Oh, okay. All right, so endometrial cancer. This is no surprise to anyone that we do not have good, effective treatments once patients recur. There's limited efficacy in patients with previously treated cancers. Looking at all the phase 2 to 3 studies over the last few decades, the response rates varies from 4% to 11, 13%. And then with letrozole and everolimus, we started having a bumping up with some of these newer targeted agents. But overall, the efficacy in previously treated patients is very poor. The other misconception that we have with endometrial cancer is, oh, this is an early stage, early grade disease. You're going to be all right. Well, that's true for 2/3 of patients, but we have 1/3 of patients who are going to have advanced or metastatic disease. The incidence is increasing, and the mortality is increasing. And the mortality increasing is contrary to everything we're always hearing about how we're beating cancer all the time. The mortality for endometrial cancer is going up. And so this is the population of interest, the population where patients have high-grade or advanced stage disease or metastatic disease. This is a population of interest because people are dying more often. So the reason I put this slide up of what our therapies is the whole definition of insanity is doing the same thing, right, over again, expecting different results. Well, we did the same thing here. How many? Can someone count how many of those? What is it, like 12, 14 studies? We did the same thing over and over again, not selecting patients for trial, just looking at all endometrial cancer patients together and then throwing a chemotherapy drug at them and hoping that this is going to be some golden bullet that changes everything in endometrial cancer. And so that's partially insane. And so it's very exciting that we have a newish way, which is not very new anymore, but our applicability for this way, our ability to apply the molecular staging of endometrial cancer to clinical trials is a potential game changer. It's a potential not doing the same thing over and over again. Because the amount of studies that we probably wasted money on and wasted patient years on trying to do unselected treatment arms for patients with just endometrial cancer is someday we're going to look back and see how much time and money we wasted doing these studies. But this now is entering into the clinical research arena, meaning it's coming out of the lab. It's coming out of Sophia's hands in the lab, and it's entering into, my territory, which is like not as smart as Sophia, like just a basic clinician like myself, right? It's entering into our territory right now. It was previously just the really smart folks in the back, and then now it's with me. So with the TCGA, we had our newly defined 4 molecular subtypes, and this is not new, right? This is year 2000 stuff. But the four categories that we've had from TCGA is POLE, MSI, microsatellite unstable, copy number low, copy number high, right? And for the longest of time, they're like, well, we are not doing whole genome sequencing on all these tumors to know what's what. But we knew from the beginning that these classes have prognostic implication, right? We look at the POLE patients, those patients rarely ever recur. And then we look at the copy number high patients, which are the serous light group, and those patients have the worst outcomes, right? And then in the middle, we have the MSI and the copy number low. But again, we weren't doing whole genome sequencing in clinical practice. Like for me in the clinic, I never know who's copy number high and who's who's copy number low. But then we started looking in more detail into it. And is there surrogates of what we're doing in our clinical practice with universal molecular screening of patients and with doing next generation sequencing? When you actually other areas, the POLE patients are the POLE patients. Those patients have the best outcomes. But then looking at once we started doing universal microsatellite instability testing on patients, we can use the immunohistochemistry to immediately identify the patients that are microsatellite unstable or MMR deficient. And once we did that, we've taken that second group out of the equation. So now we have two groups. And so just if all we have left are the copy number low and copy number high, we can compare, and looking right here, if you just look at the P53, where's the P53? It's right here. This is P53. None of the copy number low, well, one, but 99% of the copy number low are P53 wild type. Whereas the copy number high are all P53 mutated. So then just using those surrogates, so you know your POLE from your Caris report, you know your mismatch repair deficiency from your immunohistochemistry, simply looking at the P53 will allow you to segregate patients into copy number low and copy number high. And that is a game changer because doing this, it puts it back in our hands as clinicians. And so why does this matter? And I started this by telling you, like, we're doing the same study, this unselected study over and over again. This is PORTEC 3. Everyone here knows PORTEC 3. I'm not telling you anything new, right? We're comparing chemoradiation with radiation with chemoradiation, correct? And we did this on like thousands of patients, and these are the graphs. And one of my old mentors used to say, if you can't drive a truck between those graphs, then you just wasted a whole lot of money. And you can't drive anything between them. You can't drive my daughter's tricycle between those graphs. So what that means is we gave up on trying to find the difference between. But wait a minute. What happens when we actually apply this molecular classification? First of all, applying the molecular classification, P53 abnormal, POLE, mismatch repair deficient, and no significant mutation otherwise, we had the segregation in our survival curves. So first, it applies in real life. So good. But then what happens when we actually apply it to the two curves and look at if there's a survival difference between chemotherapy and radiation once we segregate patients into these four groups? So the first thing is, looking at the POLE mutant, no one recurred. So just think about this. We randomized patients to get 6 cycles of chemotherapy and radiation or radiation alone, and this is how well they did. So significantly overtreating. But then look at this right here. Once we broke it down by P53 abnormal or normal, there was a significant survival advantage to using chemotherapy. So this is not only clinically applicable, this will help you in clinical practice. Now, clearly, this is hypothesis generating. This is an unplanned subgroup analysis, just to show the point. But with PORTEC 4a coming up and with all the new studies, this molecular classification is everything. This is going to really dictate our future of how we can utilize precision medicine properly beyond just being a slogan of tailored treatment for patients, right? So the P53 patients did significantly better with chemotherapy than with radiation. And then the other two categories, there was no difference in outcomes still. So at least through this, you identify in a hypothesis-generating way who could potentially benefit from chemotherapy in addition to radiation. So there's a lot of value in this. So this is something that's more and more coming to and I couldn't start to talk about endometrial cancer without talking about this because I think over the next decade, most treatments are going to be quantified in this direction one way or the other. So shifting gears and trying to wrap up 2 years worth of work in 20 minutes. We're going to jump quickly, but if anything needs clarification, don't hesitate to stop me or we can talk about it at the end. This year was a big year for immune checkpoint inhibition, right? Traditionally, checkpoint inhibitors, we have had all these historical single agent trial. The response rate was okay, right? The response rate was okay. So in patients, in Keynote 158, in advanced stage cancers that were deficient, we had a 48% response rate. With the FIDERA trial and durvalumab in mismatch repair deficient patients, 43%, 26.7 with avelumab in stage 2. So for the mismatch repair deficient patients, we knew that these immune checkpoint inhibitors did well. But the problem was in the mismatch repair proficient patient populations, patients who did not have microsatellite instability. And the initial single agent studies showed that these drugs really don't work on their own. So looking at Pembro in Keynote 28, the overall response rate was 13%. 3% with Fidera, durvalumab, as a single agent in mismatch repair proficient. And so clearly, if this was the old days, we would have said, well, this doesn't work, and let's move on and try to find another drug, right? But 2023 was the big year for checkpoint inhibition. And we actually had, we had 2 major clinical trials combining checkpoint inhibition with chemotherapy in the upfront setting. So you had on one hand GY018, which randomized patients with stage 3 to 4 or recurrent endometrial cancer to receiving carbotaxol and placebo or carbotaxol and pembro. And you had Ruby, which was carbotaxol and dostarlimab or carbotaxol and placebo. And there was maintenance of up to 3 years in the study, and the patients, both the endpoints were progression-free survival as a primary endpoint. And you could drive a truck there, can't you? So Ruby Part 1, this is the hazard ratio was 0.28 of adding checkpoint inhibition. 0.28. Like this was one of the first times I ever saw a hazard ratio this impressive. 0.28. Your patient was 70% less likely to die or less likely to progress, because this is a PFS outcome, if she got checkpoint inhibition in addition to chemotherapy. And that's on Ruby. And with GY018, the hazard ratio, not surprisingly, was a similar, and it was 0.3 if I'm not, yes, 0.3. 0.3 was the hazard ratio for progression. And this is in the mismatch repair deficient. But what about the mismatch repair proficient? Well, with the difference was less impressive, but it was still impressive. And you had a hazard ratio of 0.54 on GY018, and in Ruby, your hazard ratio was 0.76. So these were still statistically significant. And the companies, in their quest to get these drugs quickly approved, only applied for registration in the mismatch repair deficient population. And so based on these data, we got approval of checkpoint inhibition in addition to chemotherapy for patients with mismatch repair deficient cancers. But the data for it's very important to note that the data for mismatch repair proficient tumors are still statistically significant. And looking at the long-term overall survival, and this is at 33% maturity, the p-value, and I put this because sometimes we just say significant and insignificant, and we forget that it's a spectrum of significance as well as a spectrum of insignificance. And the p-value here is 0.0021 for a hazard ratio of 0.64 in the overall population. So this is looking at all comers, patients who are proficient and deficient. And this was in Ruby. And this was presented last year, I think, at ASCO. But then looking a little further here, looking at the molecular classification, and this was presented like 4 months ago, these data, looking specifically at the mismatch repair status, because I was interested, does it matter what the other classification is? Because we know about mismatch repair deficient or proficient. What about the POLE patients? And how often do we actually see POLE when we don't select for it? And POLE is pretty rare. Even though those patients do very well, it was 1.25% of the time the patients had POLE. So it's not something that we see every day. We always hear these, every molecular stump the professor conversation, I have someone brings up to me, hey, what do you do when you have a POLE? I was like, I'll tell you when I see one. Because I've probably seen like 3 over the last, with all the volume that we see, that I can think of. It's not very common. But also looking at this identified that the biggest group of patients that we see in these populations, 54% of the patients were NSMP patients. And those are the patients that aren't the P53 abnormal, the poorest risk factor, and they're not the deficient groups, which are 22.7%. So the reason I bring this up is because if we only limit these data to patients who are in the mismatch repair deficient group, we're missing 75% of the patients. And those patients also receive benefit from addition of checkpoint inhibition. So very near in the future, I do believe that this is going to be included in our guidelines. And it's just going to take some more studies to bring this up. And looking at the outcomes by, and again, this is, please do not take this as like, these are non-randomized data. These are subgroup, unplanned ad hoc analysis, right? So these are not These are, again, hypothesis generating. But you can even see, like, the patients who do have mismatch repair deficiency, the difference is incredible between survival for those patients. But there is still a difference when you look at the NSMP group and when you look at the P53 mutant group. So there is still significant differences. And what happens here? So maybe there is a group of patients that don't benefit from adding Pembro because they're going to do well regardless, right? So this is, again, knowledge is power. But again, this is 1.25% of your patients. So we won't get overexcited about this, but it's good to know. If you happen to come across a patient, and again, this is really relevant when it's difficult to get the drug, right? And we're talking about, like, what do we do politically? Let's say we're going to try to minimize cost. Well, we know that potentially patients who are polymutant, those patients might not need to add the checkpoint inhibitor. So then, of course, we didn't have enough there. We had to go and muddy things up even further and combine these drugs with each other. So you heard all the talks by Dr. Schlumbrecht, who's a far more eloquent speaker than I. But you heard his talk on PARP inhibitors in ovary cancer. Well, what about the role of PARP inhibitors in endometrial cancer? And is there a role to combine them with checkpoint inhibitors? And so this is the first study. This is the same two parallel studies that happened. This is DUO-E here. DUO-E was randomizing the same patient population to getting induction chemotherapy for 6 cycles and then maintenance with just placebo, or maintenance with continued durvalumab alone, or maintenance with olaparib plus durvalumab. So those were the 3 arms. And then on Ruby Part 2, it was simpler. It was dostarlimab, niraparib, or placebo. Those were the 2 arms. And we had this was in was it May? May. Yeah, it was in May of 2023 where we had the press release, and they had to keep us on the edges of our seats for about 3 months while they actually released it. Because, you know, these are all publicly traded companies, so they're legally obliged to let you know when they have potentially positive data. And so this was a press release that came back, which is Imfinzi plus Lynparza and Imfinzi alone significantly improves PFS in advanced endometrial cancer. And then we got the data in ASCO, which showed that the combination of durvalumab plus olaparib was superior to the durvalumab alone, and which was superior to the control arm. So that combination, the PFS benefit, was observed both in the durvalumab arm and in the durvalumab plus olaparib arm, but it was even higher in the durvalumab plus olaparib arm. And of course, this is like intelligent clinical trial design. The comparator is the patients who get placebo, not to each other. So that's just with the way they designed that trial. And these are the OS curves as well. And when you look at it by subgroup analysis, and this is again very interesting, looking at by molecular subgroup. Super interesting is trying to understand here that when you had MMR deficient patients, there was no benefit to adding durvalumab, olaparib to durvalumab, because really they're getting so much benefit from the checkpoint inhibition that adding a PARP to it might not be useful, right? But when you do break it down into patients who, and this is 80% of the patients in this group were proficient, when you break it down in this way, the durvalumab plus olaparib arm did better than durvalumab alone. So here again, if we just took all these patients together, we might have not have known where the benefit is. But this is clear. If you have a patient with a mismatch repair deficiency, there's no point in adding another toxic agent on top of another toxic agent if they're going to have so much benefit from the durvalumab alone, which is what I showed you in the first part of Ruby and the first part of GY18. But if you have someone who's proficient and they have a smaller benefit, adding the PARP inhibitor is going to help. And then of course we have to push even further, right? And one of the trials here is called Dominica. I'm just putting the shout out there, but Dominica, we'll start with that because of the group, is randomizing patients who are mismatch repair deficient in the upfront setting where chemotherapy has always been the standard of care, and we just showed that adding checkpoint inhibition to chemotherapy improves their outcomes. Well, can we get rid of chemotherapy altogether? Can we put these patients on just checkpoint inhibition? And so in Dominica, we're randomizing those patients who would otherwise get chemo plus checkpoint inhibition to either dostarlimab or chemotherapy alone. I mean, that's incredible. This is over the course of my short career, we've gone from just everyone gets slammed with chemo to now potentially getting rid of chemotherapy for a specific subgroup of patients. And for us nerds, that's incredible. 3064 is the same study, but the checkpoint inhibitor is Pembro instead of dostarlimab. And then what about the mismatch repair proficient? Well, it's randomizing Pembro and Lenvima to chemotherapy alone. And again, can we get rid of cytotoxic chemotherapy in the upfront setting? I think this is very exciting data. What? You have a question? Huh? No, this is upfront. Yeah, so this is all usually stage metastatic, like so stage 3, 4, or recurrent. So those are patients who would otherwise be getting chemotherapy. Yeah. So those are the so dMMR and pMMR for the pembrolizumab group. So I think this is very, 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 very exciting data, and I honestly can't wait to see these results. And I'm sure next year is going to be a big year. Actually, most of these trials are probably going to get published in 2 years, I think. So we have some of our industry colleagues; they probably have more information about when. You can feel free to ask them. All right, so this is another really, really, really interesting story. And I tried to focus in this talk on stories of how the molecular classification changes things. Because we are always complaining about this new staging criteria that we are dealing with, right? The new FIGO staging. Everyone's complaining about it. We're complaining about it all the time. We have a quarterly meeting to discuss it. And every quarter we defer decision making for the next quarter. Just so you know, we've had the meeting 3 times. But the reason I'm bringing this up is because this classification, watch what it did here. So this is a Selexor study. Selexor, this is the long-term follow-up data. So I'll go through this, the drug, the molecule. So Selexor is a targeted oral XPO1 inhibitor, okay? And for the rest of us English speakers, XPO1 is a nuclear transport protein. Okay, so what XPO1, so nuclear retention and functional reactivation of tumor suppression genes is dependent on XPO1. Without XPO1, you cannot transport these proteins out for them to be transcribed and then for them to be effective. Selexor inhibits XPO1. So what essentially Selexor is doing, there are multiple mechanisms in which it induces cancer cell death, but in endometrial cancer, it's likely through the nuclear retention and reactivation of tumor suppression proteins, such as p53. So just pausing for a second here, if there is a drug here that works specifically by reactivating a protein that works, it then follows that it would only work in patients who have a normal protein. So if the p53 is mutated, this drug's not going to work. Does that make sense? Because you're reactivating a protein that doesn't work. So that's not going to do anything. So that's just theory. But they didn't think about that. They initially, when this trial was designed, they was like, this is exciting. Let's slap it on everyone. But we know better now, right? Okay, so allows for reactivation of p53. And when we looked at it in the overall population, and this is the graph on the patient's right. There was no difference in outcomes. It wasn't significant. The hazard ratio was 0.7, but the confidence interval, it was significant. The hazard ratio was only 0.7. And it doesn't look that impressive for someone to be on a maintenance drug for all that time for just this. However, and this is a pre-specified exploratory endpoint based on our knowledge of how this drug works. When you look specifically at the p53 wild type group, this is the difference in the survival outcomes between the maintenance and not. So think of this. The placebo patients had a progression-free survival of 3.7 months. The Selexor patients had 13.7 months. Big difference. And that's by knowing. But whereas when you looked at the unselected group, the difference was 1.2 months. Like, I'm not putting a patient on a maintenance therapy that's God knows how expensive for 1.5 months. Not that not all life is precious, but there's the cost of medicine as well. However, in this case, if it means the difference between someone living 4 months and someone living 14 months, this is a big difference. Or progressing after 4 months or 14 months, that's a huge difference. And so this is really, again, looking at it through the power of of knowledge of these molecular subclassifications. And then the long-term outcome that was presented at ASCO last year, this is again, the hazard ratio was 0.4 for the patients with P53 wild type, and the mutant patients had their confidence interval completely crossed 1. So it was non-significant in patients. And this makes sense because this is how the drug works. You know, there's no point in allowing the function of a mutated protein, right? So you're allowing the function of P53, which is normal, and it's suppressing the tumor and killing the cancer cells. And that's essentially how it works. But then what happens when even going further deeper into the molecular classification, when we compared patients by mismatch repair proficient or deficient? And look at this. All these patients have, both these patients have wild type, P53. But then when you compare them between the deficient, it was 13.1 months versus 3.7 months. When you look at the proficient, we didn't even reach our endpoint for the combination of Selexor. So looking at these data, the highest impact group for this drug is going to be your P53 wild type with mismatch repair proficient. And that's our highest, biggest group of endometrial cancer patients. That's that 50% that I showed you earlier in Ruby. And now we have this randomized controlled clinical trial, which is Selexor versus placebo at 60 milligrams weekly. And the primary objective is with patients who are only P53 wild type, and it's going to be stratified by MMR proficient or deficient. And this is going to be the registration trial. So in the near future, you're going to hear about Selexor. You heard it here first. So final thing, this is really interesting and exciting. And I thought I was giving the talk after the updates in ovary cancer talk. So you'll hear all about mirvetuximab. This slide looks this shabby because this data is 2 weeks old. It was literally just presented. I didn't have time to make a good slide for it. But this is looking at mirvetuximab, which is a folate receptor alpha antagonist we're using in ovarian cancer, and combining it with pembrolizumab in patients with microsatellite stable patients. This is a phase 2. It was just presented at ACR a couple of weeks ago. Was it 3 weeks ago? 3 weeks ago, ACR. And looking at patients who are advanced, recurrent, microsatellite stable, proficient, folate alpha receptor positive of 50%, which is different than what we use in ovarian cancer, and getting MIRV plus Keytruda, you had 31.3% partial responses. Remember, single agent pembro in the setting, what did we say? We said about 12%, 10%, 10 to 12%, depending on the study. You got it up to 31.3% partial response by adding the folate receptor antagonist, 6.3% complete response. This is in the recurrent setting. And then 31.3% stable disease. So we're looking at about 70% clinical benefit rate with this combination. So all I can say is thank you so much for your attention. Sorry about the technical difficulties, but the future really is bright. We're going to do and continue to do more and more with molecular medicine and precision medicine and endometrial cancer. And if you need to get a hold of me, you have my information from the first slide. Thank you so much for being here.
Hello, everyone. It's a pleasure for me. It's an honor to be part of this academical program, and I'm very glad to be with you with this summary because, you know, the previous colleagues that described the utility of the PARP inhibitors and the news on endometrial cancer, this is a brief summary of this information. As already mentioned, I am a medical oncologist in the Roosevelt Hospital in Guatemala City, and additional to my clinical practice in this hospital, I have a role as a local PI and sub-investigator for phase 2 and phase 3 trials, and also in charge about the epidemiological investigation on the oncology unit. So, okay, let's get started. This is the disclaimer for this presentation. Regarding ovarian cancer, the involvement of the treatment of this disease has important events in the large of the history. First of all, in 1934, with the description of Dr. Meeks from the Mass General about the tumor resection importance and the bulking surgery before action, the radiation therapies. Then the inclusion of Mefalan in the treatment for these tumors, you know, given a role of chemotherapy for the treatment of these aggressive neoplasia, and they all changed about the 1975 with the inclusion of cisplatin in the strategy for this aggressive cancer. So with these two phase 3 trials, the addition of paclitaxel was confirmed as a standard of care and the backbone chemotherapy for this neoplasia, comparing the cisplatin cyclophosphamide versus cisplatin plus paclitaxel, and improving in terms of the complete response rate, overall response rate, and median progression-free survival and median overall survival. Despite of these benefits, the tolerance of this combination was poor due to the hematological toxicity, neurotoxicity, and the hematogenic effect of cisplatin. So, sorry. So then, in early 2000, phase 3 trial combining carboplatin plus paclitaxel became the new standard of care. After there is no difference in terms of efficacy to paclitaxel and cisplatin with this regimen, but just associated with a better tolerability and quality of life. Then after the addition of bevacizumab as monotherapy in the first-line maintenance, do not improve longer benefit, but yes, it's a statistical benefit in terms of progression-free survival. And in the groups of high-risk population, like residual disease, incomplete surgery, and stage 4 disease, there is a benefit in terms of overall survival. And from that, bevacizumab is still recommended in international guidelines for the maintenance in ovarian cancer in the first-line setting. And as you already reviewed, the classical management of the ovarian cancer was starting over the role of multidisciplinary team with the debulking surgery, and next adjuvant chemotherapy. And as we know, in certain countries there are limitations to the access of, for example, PARP inhibitors, so inclusive to bevacizumab, observation still has a role. No all the countries, first of all, in Latam, has access to this target therapy, so then observation still has a role in this patient, and then retreatment when there is a symptoms or elevation of tumor markers. And now, as you already reviewed, the bulking chemotherapy and maintenance therapy is the standard of care in first line for patients with advanced ovarian cancer. So about how can we use the last data to guide the decision making in maintenance in first line. This is just a summary about the trial that you already reviewed. But as you already know, the monotherapy with PARP inhibitors is an effective treatment in the first line setting. So with two prospective phase 3 trials with niraparib demonstrating benefits in terms and progression-free survival, the study for rucaparib that is positive in terms in this setting, in this objective, and for the olaparib trial, solo one, in the population with BRCA mutated tumors. It is important that there is no face-to-face trial comparing the PARP inhibitors, but looking about the clinical behavior of this disease, there is a risk factors that maybe make a difference between the population, including on these clinical trials. Knowing that this high risk factor from the clinical point of view is the stage 4 disease, visible residual disease, or no surgery, or incomplete surgery, or in patient with has a bulky disease and receive neoadjuvant chemotherapy. Partial response to chemotherapy is a marker, as a predictor for, the slides. In looking for these aggressive characteristics in the PRIMA trial, there are more patients with residual disease, visible disease in tomography and CT scans, and patients that already received neoadjuvant chemotherapy. And I believe this group of patients were more frequent in the aggressive perspective in the PRIMA trial, and the addition that a good group of patients with BRCA wild type profile. So it is important to remember that the patient, including the maintenance trials, are those with good performance status and at least partial response to chemotherapy as induction regimen or cisplatin and carboplatin. Paclitaxel and carboplatin. But the recognition of HRD, including the BRCA mutated status as a biomarker in ovarian carcinoma, has a change in the clinical practice because knowing this, we can predict the prognosis of the patient and classically select patient to receive treatment with PARP inhibitors. But the biomarker is a complex formed by a diverse analysis, and due to the heterogeneity of ovarian carcinoma, this characteristic is important to know for individualize the treatment for the patient. There are data that HRD is correlated with a better prognosis independent of the treatment of the patients. Maybe this is a reflect of the platinum sensibility in this neoplasm. And HR status does not predict who patient will no benefit from PARP inhibitors maintenance. So this is because in the trials in the patients with HRD profiles in the status, there is still a benefit, even if we treat this patient with maintenance, they did achieve a benefit in terms of progression-free survival and overall survival. But there is difference in terms of the assay to determine the status of HRD. And this maybe is more confused to translate all the information from the biological behavior from the trial to trial. But the message I think is the HRD testing should not be used to exclude to the opportunity for a patient to receive PARP inhibitor. Besides that, it's informative and prognostic to the patient to be more comfortable when you show the data about progression-free survival and overall survival. And when we have the information about the phase 3 trials in the first line, all patients achieve a benefit in progression-free survival with the maintenance therapy in the setting of the patient with a deficit in HR. Now, knowing that this is a standard of care in the first line maintenance setting, we are looking to establish what about the patient that not respond or recur promptly about inclusive with the using of PARP inhibitors. So the Solo, Prima Prime, and Athena is established these 3 drugs as a standard of care and approved by the FDA and EMEA. And now some combinations like PARP inhibitors and bevacizumab still wait for mature data on those clinical trials. And there is a controversy about the results about combining PARP inhibitors plus immunotherapy like PD-L1 inhibitors and PD-1 inhibitors, because some trials like a combination with atezolizumab or combination with avelumab show negative data. So we are looking for the information about, for example, niraparib plus dostarlimab, olaparib plus durvalumab, or the result combining niraparib plus pembro. So this is a brief summary of data you already reviewed. The efficacy contribution of bevacizumab plus PARP inhibitors has not been established in prospective. We are waiting for the data from this trial that we already mentioned. The risk-benefit of the chemotherapy, the escalation in combination with PARP inhibitors in the neoadjuvant setting is still being explored. With these positive effects in patients with maintenance therapy, the idea that it has a role in the neoadjuvant setting. Maybe we're gonna like to explore these results because patients with acute pathological complete response is related with better outcomes only with chemotherapy. So augmenting this rate of patients with complete response may be influenced in the future for the strategy in the adjuvant setting. And combining therapies with PARP inhibitors may provide therapeutic options in patients who may not benefit, for example, with this strategy today, you know. And other important thing is characterize the molecular subsets. You know, there is new information about subgroups of patients based on HR status or BRCA mutated status. It is still a standard of care to perform these biomarkers, and in the future, the ovarian cancer management may be consistent in combination of these target therapies in the first line, including the PARP inhibitors, awaiting from the data about combination immunotherapy, like, you know, the PD-1 inhibitors, and combination, for example, with bevacizumab. This ongoing trial are going to give you this answer for this patient that is still progressing besides the use of these novel therapies. So this is the first part for the talk, and then we're gonna move to the endometrial cancer review. So, you know, the endometrial cancer has an increasing incidence, and this disease, when recurs or presenting as a metastatic disease at the beginning, has a important aggressive behavior. You know, has a poor prognosis compared with ovarian cancer, and will surprise in a moment if this is continue the mortality of the ovarian cancer if we don't find a better treatment for this population. So the immuno-oncology strategy for the endometrial advanced carcinoma is based on 3 strategies: combining chemotherapy plus immunotherapy, combining chemotherapy plus PARP inhibitors, and monotherapy of the immunotherapy with other combinations. So the rationale and biological rationale of combining chemotherapy and immunotherapy is well described about diminution of myelo-derived immunocell that made a immunosuppression by depleting or inactivating the T cells. And the chemotherapy may influence these cells has depleted and lead to the lymphocytes in the microenvironment tumor can attack the tumoral cells. And the death of the tumor cell can lead an increased expression of tumor antigens, and this improves the results of the immunotherapy. Based on this biological statement, there is several programs combining PD-1 inhibitors like dostarlimab, pembrolizumab, durvalumab, and atezolizumab ongoing. And for example, for the RUBY trial that you already reviewed, we're gonna take a few moments to describe what about the result with this combination. Pembrolizumab has important data with combining chemotherapy plus pembrolizumab in patients with deficiencies in mismatch repair mechanisms and the overall population, and this data is still ongoing from results. So the design for the RUBY trial has 2 parts. One, including only dostarlimab plus chemotherapy following dostarlimab maintenance for 3 years, compared with placebo plus chemotherapy. In the part 2 trial, the interventional difference is the addition of niraparib plus dostarlimab. So we're going to discuss the result only in the part 1 of the trial. And this, if we look the design of the trial with pembrolizumab plus chemotherapy, in the part 1 is pretty much the same, you know, starting with chemotherapy plus pembrolizumab, and then maintenance with pembrolizumab, compared with placebo versus chemotherapy, plus chemotherapy. So the rationale of the use of this combination of dostarlimab and pembro became from the Garnet and Keynote 158, because these trials are positive in the second line scenario with good responses in terms of progression-free survival and approval for these drugs in this setting. And the combination of antiangiogenic therapies like lenvatinib plus pembrolizumab as already approval in this setting in the second-line patient with endometrial carcinoma progressing after chemotherapy based on platins. So for the phase 3 RUBY trial, the rationale is that the combination of immunotherapies plus chemotherapy has a clinical benefit in multiple tumors with a synergistic by leveling the rapid tumor response, enhancing immunogenic cell death, and reducing the immunosuppression of the tumor microenvironment. So when you look for the dostarlimab activity in this tumor with deficit of mismatch repair, has a robust information about his high activity. And chemotherapy, you know, there is a biological rationale that enhances immunogenic cell death and reduce the immunosuppression in the tumor microenvironment, leading there a broad activity of these anti-PD-1 antibodies. So the study hypothesis is combining dostarlimab plus chemotherapy improve the outcomes in this population and overall population in the primary advanced or recurrent endometrial cancer population versus the chemotherapy alone. There is a resume of the design of the trial and the eligible patients. The important of this trial is they receive other subtypes of uterus cancer, like, for example, carcinosarcoma, clear serous, or mixed tumor that generally has a proficient mismatch repair mechanisms. But in all of these subtypes, the expression of PD-L1 is maintained. So based on that, all the subtypes of endometrial cancer were received. First of all, endometrial carcinoma was the first of all histology in this trial. And the stratification was based on the mismatch repair status and prior external radiotherapy based on the effects of radiotherapy in enhance the activity of the immunotherapy and the disease status. Remember that these patients could have a locally advanced disease and inclusive patient with no measurable disease, but data of recurrence local, even not measurable for a CT scan. So the scheme is that you already know about 500 milligrams of dostarlimab combined with carboplatin and paclitaxel as habitual dose, and then a maintenance therapy with dostarlimab at 1,000 milligrams every 6 weeks for 3 years. This is a main difference when you compare with pembrolizumab, because only goes for 14 cycles every 6 weeks or about 2 years. And this treatment is given until the disease progression or unacceptable toxicity. The endpoints was the progression-free survival evaluated by the investigator, but the progression-free survival was evaluated by the independent committee, and the overall survival has powered for primary endpoint 2. There is important secondary endpoints like overall response rate, duration of response, disease control rate, and the quality of life and security data. The inclusion criteria, as we previously mentioned, include patients with locally advanced disease, recurrent disease, and stage 4 disease at the beginning with a good performance status, and the patient will receive needed neoadjuvant chemotherapy or adjuvant chemotherapy have had recurrent or progression at least for about 6 months after the treatment completion in the first recurrence only. And the exclusion criteria was similar for the other trials in the immunotherapy setting. For example, like the patient had no progressive disease after the first dose in the adjuvant setting, at least one disease recurrence, prior therapy with anti-PD-1 or PD-L2 inhibitors was criteria for this, no exclusion criteria for this trial, and uncontrolled central nervous system metastasis was habitual exclusion criteria for this trial. And then the vaccination status of the patient was evaluated 30 days previous to the start of the first dose of the interventional treatment in this trial. The primary endpoints, as I already reviewed, was the progression-free survival and overall survival, and then all the secondary and exploratory endpoints, including biomarker analysis and ctDNA analysis and MSA status analysis. From the statistical point of view, has an interest design with a p-stopping value boundary in the first interim analysis for evaluating the progression-free survival in the subgroup of this management repair or MSA high patients, and in the intention to treat population for the progression-free survival. And this is a good idea because if this benefit is not found in this interim analysis, you can stop or analyze what happened with this patient, but I believe that they already expect a good response in this group of patients. So this is the design that we already discussed about the chemotherapy and combination plus dostarlimab and then dostarlimab maintenance and the frequency of all the cycles with the maximum of treatment with chemotherapy with six cycles, starting in the cycle number 7 with the maintenance dose of dostarlimab. This is the flow chart of the protocol. Remains on treatment 21% of the patient in the experimental arm versus in the group of placebo, only 14% of the patient. The main causes of discontinued treatment was the progressive disease, adverse events, and clinical progression. Additional, patient lost the following up. When we analyze the progression-free survival in the interim analysis, at the primary endpoint of the trial, this is impressive difference in favor to the intervention with dostarlimab plus chemotherapy versus placebo, with an impressive reduction of risk of progression with a 72%, with a statistical benefit based on the pre-specified criteria. And the overall population, even in patients with a proficient mismatch repair status, this benefit still was found, but with a spread or with a reduction of the risk in 36% of the patients treated with the combination of dostarlimab plus chemotherapy versus placebo. The overall survival as a primary endpoint in the overall population was positive. And this is important because this led to the approval of this regimen for regulatory agencies, inclusive with the no data about the other histologies for all patients with independence of the biomarkers and the histology. There is a benefit adding this combination in terms in overall survival with a reduction of risk of death of 36%. In the pre-specified subgroups, in patients with has deficit mismatch repair or MSA high patients, the benefit in overall survival was impressive with a reduction of risk of death of the 70% compared with the placebo group. And dostarlimab has a subsequent use of immunotherapy in the 38% of the patient and the placebo group in 15% of the patient, leading to interpret this no effect in the data of the overall survival analysis. And the patient with proficient mismatch repair also have a benefit in the overall survival, combining dostarlimab and carboplatin. In terms in overall response rate, complete response and partial response, both regimens are similar in this setting, but when we look about the complete response in patients with this much deficient mismatch repair, we look at benefit in numerical terms in the group adding dostarlimab to the chemotherapy. And this result in patients with proficient tumors are very the same with adding dostarlimab compared with chemotherapy alone. In the overall population, there is no numerical difference in terms of response. In the secondary endpoint of progression-free, in the second progression-free survival, in patients with deficient mismatch repair, still is a benefit from adding dostarlimab plus chemotherapy compared with placebo. And even in the group with proficient in the overall population, this benefit still maintains over the population with the second progression-free survival analysis. And this only confirmed the following of this data. In what about adverse events? As you know, the immunotherapy has been related to some adverse events, and even dostarlimab has no adverse events like infusional-related adverse events and skin toxicity. When we analyze the data of the grade 3 adverse events related to the combination to dostarlimab plus chemotherapy, some points are important to mention. Principal, one death was considered to investigate to dostarlimab in one patient with myelosuppression in the face of combination with chemotherapy. One patient experienced hypovolemic shock in the arm of dostarlimab, and then 3 deaths are related not to the treatment, but just an overdose. There is no specific related, if the overdose is from chemotherapy or, for example, dostarlimab, COVID-19, and general physical deterioration. In specific adverse events, the rash was the principal adverse event related to dostarlimab with 22%, plus carboplatin and paclitaxel versus 13% in the placebo group. And the macular papular rash has a 14% in the dostarlimab group versus only 3% in the group of the placebo. So this look for the multidisciplinary care of this patient, including dermatologists for the management of these adverse events, or the management prepared with, hydrating with the skin care in this group of patients. But then these are expected adverse events from dostarlimab, and no new adverse events was detected in this clinical trial. The frequency in general of grade 3 or more adverse events with dostarlimab was already about the 10% compared with placebo. And when you compare hematological toxicity, there is no influence of the dostarlimab in increase the toxicity related to the chemotherapy. And finally, the author conclusion was with this data, 72% lower of the risk of progression or death in this group population, and 36% or lower risk in the overall population makes this regimen now as far these days, including all the histologies, a new standard of care in this group of patients, combining dostarlimab plus carboplatin. The progression-free survival at 24 months was clearly different between the groups, 61% versus 15% in the chemotherapy-only group, and dostarlimab plus chemotherapy show a benefit in progression-free survival, even in the population with proficient mismatch repair status. Dostarlimab plus carboplatin show a consistent benefit in terms of progression and overall survival in this group of patients compared with chemotherapy alone. Besides the curve diverse at 1 year, it remains separately with a 79% versus 58% in this group. So the safety profile of dostarlimab plus chemotherapy in general was consistent with the safety profile previously reported for the dostarlimab component, and the quality of life was similar between the dostarlimab group post chemotherapy, leading no new advice on the quality of life that was impaired with the addition of dostarlimab in this group of patients. So this is the resume that I believe you reviewed something about these trials, but thank you so much for your patience, and if you have any comment or question, I'd be happy to attend. Thank you so much.
I'll try and get there just as fast as I can. I'm going to be talking about updates in cervical cancer. I'm pretty boring. I have nothing to disclose. I am going to be talking about off-label use when we talk about research studies. Objectives, I just wanted to give a brief, very brief historical context for how far we've come in cervical cancer, and then I'm going to talk about advances in early stage disease, specifically surgical technique and modality, locally advanced disease, what's beyond chemoradiation, the prior standard of care, and then metastatic or first-line recurrence, and then also new second-line recurrence options. So over the last 100 years, it was about 100 years ago when Dr. Papanicolaou first started doing his work on cervical cytology and vaginal cytology. And you can see that from 1930 up to 1990, just pap smears alone and screening in the United States was able to take the mortality rate from 36 per 100,000 to about 7 per 100,000. But it's still a very present problem in present day. And there's wide disparities between, as we well know, that between the incidence and mortality among industrialized nations versus underserved, underdeveloped nations. And in the early 2000s, that's when we started making the development of the HPV vaccines. There's only one that's available in the United States, Gardasil 9, which has 5 additional high-risk HPV types. Gardasil, the first Gardasil had HPV 16, 18, and 6, and 11, and then Cervarix, GSK's drug, was 16 and 18, or vaccine, I should say. And the impact of vaccination cannot be understated. This is a study out of the NHS that was just published in January, looking at a longitudinal assessment of their what they call the vaccination surveillance program. And of note, there were no cervical cancer cases among the 12 to 13-year-olds that were vaccinated, and they were using the bivalent vaccine over the course of their observation. And with the big disparity is most likely due to access to screening worldwide, and there is a self-collection HPV testing that's being developed, and under the leadership of Dr. Schwambeck and his colleagues, University of Miami is one of the participating sites. So hopefully this will have worldwide implications when it's developed. So we're going to talk about treatment of invasive disease now, and traditionally stage 1A microscopic was treated with simple hysterectomy, 1B to 2A radical hysterectomy with full lymphadenectomy, and then stage 2B to 4A was chemoradiation, and then chemotherapy for 4B metastatic or recurrent. So in early stage disease, in 2018, our world kind of got turned upside down with the LAC trial. This was a multi-institutional international study that looked at doing minimally invasive versus open surgery for radical hysterectomy. And much to our chagrin, since we were pretty much doing all of our cases minimally invasive, be it laparoscopic or robotic, there was a much higher increased risk of progression and death, recurrence and death in the minimally invasive group. Some of the critiques of this study is that it was a lot of different institutions, and there was no sort of standardized methodology as far as using uterine manipulators versus not. And also it was underpowered to detect the difference in the low-risk patients with less than 2 centimeters cervical tumors. But we essentially stopped doing minimally hysterectomy at the University of Miami. And then the SHAPE trial was recently published, and this was a study looking at the very low-risk patients, basically patients that had less than 2 centimeter tumors, less than 10 millimeter invasion on cone biopsy. or on MRI less than 50% stromal invasion. They included all histologies, included LVSI as well. And they were basically randomized into either radical hysterectomy or simple hysterectomy. And the primary endpoint was pelvic recurrence at 3 years. And so they were pretty similar. There was no statistical difference in the rate of recurrence between the simple and radical hysterectomy in this study population. So it basically, it was a non-inferiority study, so it showed that simple hysterectomy was not inferior to radical hysterectomy for low-risk cervical cancer patients. And as expected, it was less morbidity, obviously. I mean, mostly urinary complaints. Any adverse events were higher in the radical hysterectomy group, but definitely urinary incontinence, urinary retention, both early and late after 4 weeks after surgery, they persisted in the radical hysterectomy group. This study was open to the surgeon. The surgeon could decide whether they did a minimally invasive approach or whether they did an open surgery. And pelvic recurrence rates were not significantly different, as we knew, but also between MIS and open, they weren't significantly different. And they concluded that for low-risk patients, simple hysterectomy is safe and MIS may be acceptable. It's not the only study that looked at low-risk groups. Published in 2021 was the CONSERVE study. Of note, they excluded patients with lymphovascular space invasion. And then just recently presented by Al Covens at SGO this year, GOG 278 was presented, which was a quality of life study looking at either cone or simple hysterectomy, depending on desire for future fertility, with full lymphadenectomy. And when you look at this is LAC trial right here, is LAC trial. But when you look at the different studies, we're pretty consistent as far as the outcomes and recurrence rates between the two groups. And so it's more data that shows that it's safe to do a simple hysterectomy or cone biopsy with lymph node assessment in patients with low-risk disease. We know that the risk to parametrium is minimal. It's less than 1% from all the retrospective data that we have. So you have to go to nodes, but you can skip the parametria. In GOG 278, they also looked at fertility outcomes, and there were 15 of the 31 patients that wanted to get pregnant or expressed an interest in getting pregnant. 15 got pregnant. 15 patients had 16 pregnancies. There were 3 miscarriages, 3 preterm, average of 33 weeks, and the rest went to term. And locally advanced disease always, well, not always, but recent history is chemoradiation as standard of care. There were 2 breakthroughs in the last year. One was with induction chemotherapy, the Interlace trial, and then there were 2 studies with looking at the addition of immune checkpoint inhibition to chemoradiation. And so, there's been conflicting data as far as overall survival with a large meta-analysis prior to initiating these studies, but they developed the protocol using weekly paclitaxel and carboplatin prior to chemoradiation, and they had paclitaxel during and after radiation for maintenance. So here's the Interlace schema. I kind of just said it, but it's basically a combination of MITO7 and 218, where we did AUC at 2 with MITO7 weekly, and then it was 80 instead of 60 for the Taxol. And then they received the standard chemoradiation with afterwards. There was a significant improvement in both progression-free and overall survival. Has a ratio of 0.65 for progression-free survival and a 0.61 for the risk of progression and death. And both the radiation was, the chemoradiation was, basically based on the standard for each place, but it was standardized across the study. And then the overall survival in the chemoradiation arm is similar to that in published literature for chemoradiation. Hematologic toxicity was obviously greater with the induction chemo, but it didn't affect the ability to complete the radiation or to start it on time. So we know from the Cancer Genome Atlas that there's amplifications in PD-L1 and 2 in cervical cancer. We know that checkpoint inhibitors from the prior talks promote T-cell activation against tumor cells. And in locally advanced cervical cancer and in patients from prior studies that are on first-line treatment studies for metastatic, up to 95% of patients are expressing PD-L1. And they account for 50 to 60% of recurrences. So Kala was looking at the addition of durvalumab, and they were randomized in a 1-to-1 to chemoradiation control, and 24 months of maintenance therapy with durva afterwards and during chemoradiation. And Keynote 18 was a pretty similar design as the Kala. So Kala, unfortunately, was a negative study. There was no significant difference in progression-free survival between the two groups. This was their primary endpoint. Keynote A18 also had overall survival as a primary endpoint. And so this is the schema for the study. And like I said, they either got the standard of care with brachytherapy versus pembrolizumab Q3 weeks for 5 cycles, and then followed by 15 cycles of Q6-week maintenance therapy afterwards. And there was a significant reduction in the risk of progression, 30% reduction in the risk of progression with the addition of pembrolizumab. And the overall survival was also statistically significant with a 26% reduction in the risk of death. So the FDA approved pembrolizumab concurrently with chemoradiation for locally advanced cervical cancer. What about metastatic or recurrent disease? We know from back when I was a fellow accruing to 204, we know that chemotherapy is chemotherapy, and you can't improve on chemotherapy until the addition of Avastin. Remember, GOG 240 was a non-platinum doublet that either included or didn't include Avastin, and we were able to gain a 5-month improvement in survival with the addition of Avastin. So Keynote 826 was a real game changer. This study was an RCT looking at pembrolizumab in addition to Taxol, cis, or carbo, depending on whether they had radiosensitizing cis previously, and also the bevacizumab. And that was versus placebo. And they continued the bevacizumab for 24 months total. And there was a significant improvement in primary and progression-free survival, as well as in overall survival with the addition of pembrolizumab to the prior standard of care with Avastin and platinum-based chemo. And when you look at the final overall survival data, there was a very significant reduction in the risk of death for patients that had a combined positive score of greater than or equal to 1. So pembro also was FDA approved for the treatment of metastatic or recurrent cervical cancer. There was another study as well, BEAT-CC, that was recently presented, and this was a phase 3 trial looking at atezo in combination with bev and paclitaxel and cis or carbo. So it's basically the Keynote, but with atezo. And again, there was a significant improvement in progression-free and overall survival with the addition of checkpoint inhibition to standard chemotherapy with anti-angiogenesis. And so this was more confirmation that checkpoints work when they're PD-L1 positive in advanced and recurrent cervical cancer. The median PFS was 13 versus 10 months, and the median overall survival was 32 months versus 22. And we have not seen survival benefits since the addition of Bev. So this is kind of where we've come. You see GOG 204 was Taxol non-inferiority, 240 addition of Bev, Keynote 826 Pembro, and then Atezo. These patients in Atezo, all patients got bevacizumab. In Keynote, it was up to the provider whether or not they gave bevacizumab. If you have somebody with a low pelvic tumor that's abutting the rectum, you may not want to give them a fistula. So it was up to the provider to add. So this is some of the conversations that we've had as a group of why we think that the Atezo was so much better than, or appeared to be so much better than the Pembro. What about second line therapy? What about after Bev? GOG 3022 looked at the addition of an antibody-drug conjugate to tisotumab vedotin. This was given until progression or unacceptable toxicity, and the primary endpoint was overall response rate. And secondary endpoints included duration of response, time to response, safety, and overall survival. So tisotumab is a tissue factor-directed antibody-drug conjugate, and it has a MMAE payload that is a microtubule disruptor. It's widely expressed in metastatic cervical cancer and, MMAE. And so when you look at the waterfall plot here, you can see that there was the large proportion of patients had stable disease, partial response, and complete response. But this is something that we didn't see before in this patient population, is complete responses. And there were 7 complete responses in this group. And the overall response rate was 24%, median duration of response of 8.3 months. Most common side effects, we know that there's a form of ocular toxicity. 60% of patients treated had some kind of conjunctival adverse reactions, be it some kind of ocular reactions, be it conjunctival or dry eye or corneal reactions, and blepharitis, basically where the eyelid sticks to the cornea. Grade 3 ocular adverse reactions occurred in 3.8%. So tisotumab got approved for use in second line, failing chemo and Avastin. So just as a summary, early stage, we now know that with the SHAPE trial and CONSERVE and GOG 278, that we can be less radical in low risk disease. Locally, there's a current trial going on looking at robotic version, the ROC trial. I didn't put that slide up here because this talk was already too busy. But that's ongoing to answer the question about minimally invasive but robotic. They exclude laparoscopic versus open to kind of seal that gap between the less than 2 and greater than 2 that's missing from the LAC trial. For locally advanced disease, 1B to 4A, we know that we need to give platinum-based chemo-RT, but the addition of chemo, if they're the addition of Pembro, if they're PD-L1 positive, should be something that you're doing. And then for recurrent and metastatic, we know that for PD-L1 positive patients, add pembrolizumab to your chemo and your Avastin. And with second line, we now have tisotumab vedotin for patients that fail the chemo with the Bev. That's all I have. Thank you for your attention. I benefited from that training. We didn't routinely send pelvic nodes for frozen. And we completed the radical hysterectomy and waited to see what the path and see if they met Peter's criteria. So we weren't aborting any radical hysterectomies. And I remember when I started as a fellow here in 2003. The first year I did 24 RADHIS, and the second year I did 22. So we're not doing near those numbers these days, but yeah, yeah. But we don't do that stuff anymore. I was doing what I was told.
And
Hi, thanks for your talk. Interestingly, the Interlace trial showed good improvement in terms of progression-free survival and overall survival. And I think certainly for our region in the Caribbean, where waiting time for radiation is so long, I think this important trial would apply significantly to us. We're probably, once given chemotherapy, either reassess, do the surgery, or at least we're treating the tumor while we're waiting to get the radiation on board.
Yeah, that makes a lot of sense. And we have patients that are underfunded at Jackson that we've done that, but we haven't done the dose dense. We've done Q3 week. So we're now converting over after Interlace to the dose dense when we do neoadjuvant chemo or I guess neoadjuvant, but it's not really neoadjuvant, but induction chemo. So.
What's been talked about. I didn't get to go to SGO this year, but it's been talked about, several times since the LAC trial. But are there theories that people have been able to kind of really consolidate around why the trial showed what it showed, and what are some of the things that can be done to mitigate those issues? Because I know that you guys, we were both in town when the results came out, and we knew that that you guys all stopped doing robotic radicals, and I, along with Nick, decided that we would continue offering them for less than 2 centimeter tumors. And one of the theories floating around at the initial presentation of the LAC trial was the aerosolization, theory of the cancer cells from the tumor. So one of my, mitigating strategies was the stapling off of the upper vagina with a GI stapler. Any thoughts on where we are with that, or what you guys think?
My belief, and I wasn't at SGO, I saw Coven's presentation since I was involved in that study, but on a Zoom. But so I didn't get to hear discussions from other people about that. But the main thought is that the uterine manipulation was the culprit, and because the study wasn't powered to determine whether it was okay to do it in a less than 2 centimeter tumor, then we can't really comment on it. I would say you don't need to after SHAPE, CONSERVE, and 278. So, but yeah, doing the circumferential purse string, and I misspoke. It wasn't a tourniquet. It was that, just to get it clamping across and stapling. But if you can do you can start a shout out, the vaginal radical hysterectomy. I did a couple of those with Joe Lucci when I was a fellow. But if you start a shout out and peel down the posterior and anterior vaginal wall, you can suture that close, and that will create a barrier. So that's one way of doing that, And you can still put an EEA sizer. I don't use sponge sticks because I think they're like sandpaper. But if you put an EEA sizer in, you're not really disrupting beyond that membrane you've created. Yeah.
And for smaller tumors, do you all do RADHIS here or robotic, or you do a simple hysterectomy? Sorry, open.
We use minimally invasive for the smaller.
Okay, and right, sure. Okay, so if there are no more questions, we could go straight on to the other presentation, which is Dr. Ian Bambury. Dr. Ian Bambury is a consultant, University Hospital, consultant gynecology, and University Hospital Jamaica. And he has a case presentation that he'll go through now.
So it's a case that was referred to our gynae oncology service. You see him? Yep. So it's a 14-year-old patient I was referring to the gynae oncology service. I'm not sure what happens in other institutions where at this age group, whether they're managed with your pediatric, if you have a pediatric oncology service. But we had invited our pediatric surgeons to be a part of this case. So there's a 14-year-old, and she was referred to our institution with she presented with abdominal bloating and abdominal distension. All these symptoms started 3 months prior to her presentation. She had intermittent cramping, abdominal pain, sharp sticking back, no fever, no vomiting, but she had urinary frequency urgency and a feeling of incomplete emptying of her bladder. So when we saw her, she was a well-looking adolescent female with appropriate secondary sexual characteristics. She had no masculinizing signs, features, and she was at normal hydration. Examination of her abdomen showed a distended abdomen. She had no previous surgeries, no scars. She had mild tenderness, but this mass extended up to 24, equivalent to 24 weeks gestation, and she had normal bowel sounds. The rest of her examination were unremarkable. So in terms of our investigations, we did complete blood count, T1Es, these are normal. The tumor marker alpha-fetoprotein levels were elevated at the time. The other tumor markers, LDH, beta-HCGs, were normal. We went on to get an ultrasound scan, and it showed a large, complex adnexal mass. We wanted to delineate where this mass was. An MRI was done. I showed that this was an ovarian mass, but CT scan was done to see if there was any metastatic disease. And they showed a complex pelvic mass with bilateral urethric compression. I guess that was the reason for her urinary symptoms. But there are no evidence of metastases. So this is the image of the MRI. You can see this mass on the frontal view, quite an extensive mass. And when we look at the side view, you can see here is the navel. And that mass is extended quite high up into the abdomen. So at surgery with our pediatric surgeons, they convinced us to do it through a fan and steel incisions. So we did an extended fan and steel incision rather than midline incision. She had ascites, acidic fluid was present. We sent her for cytology. And this was a finding. You can see on the left side a large complex mass. And on the right, ovary, there seems to be a corpus luteum cyst, but it appeared otherwise normal. So we did cytology fluid. We did a unilateral, a left salpingo oophorectomy. Part of the omentum was stuck to the mass, so we took that part of the omentum as well, and there was some peritoneal deposit. We took that as well, and we sent that to our pathologist. So this was the mass that was taken out. It was widest diameter was over 20 centimeters. So along with this was an attached omentum there, and we took peritoneal biopsies, and of course we mentioned sending the fluid for cytology. So in terms of the gross description on pathology, the specimen consists of a 6.5 by 0.9 by 8.8 fallopian tube with the attached fimbrial end, the surface of which was glycine and bears no two paratubal cystic areas. But attached to the fallopian tube was this 20 by 17 by 10 centimeter tan gray to brown intact smooth mass, and a portion of omentum was attached to that. So no normal ovarian parenchyma was noted in this specimen. In terms of the histology, section shows portion of a tuber composed of elements of all three germ layers. So you have olfactory epithelium, choroid plexus, mature adipose tissue, but there were areas of immature elements that were seen there as well. And within the omentum, there are multiple nodules of varying sizes, largest being 5.1 millimeter, and these are of mature glial tissue that were identified. And this was in keeping with gliomatosis peritonei. So the conclusion from the pathology was that this was an immature teratoma, high grade, stage 1C3, with gliomatosis peritonei in the omentum. So this patient recovered well from surgery, and she was referred to the pediatric oncology service for chemotherapy. So we know ovarian neoplasm, very rare tumors in this age group, and represent about 5 to 7% of all ovarian cancer. And in one study that we looked at EOA in terms of a 10-year review, in terms of these ovarian tumors in that population, immature teratoma was actually more common than in the literature, dysgerminoma that we would normally have seen. So surprising in our 10-year review. So most of these are diagnosed as stage 1 disease. Median age is 16 to 20 years, and certainly fertility sparing is what we tend to do regardless of the stage, because these tumors tend to be quite chemo responsive. Stage 1 dysgerminoma or stage 1 grade 1 immature teratomas can be observed. Any other stage or any embryonal or yolk sac tumors usually require chemotherapy. And so in this index case, the stage 1C, so immature teratoma, and hence chemotherapy was given. What's interesting in this case as well was the presence of this gliomatosis peritonei. And it seems that the pathophysiology of this is that it is driven by the tumor. What is seen are these deposits in the omentum or the peritoneum, and sometimes it can be confused as peritoneal carcinomatosis. Yes, but it wasn't. In fact, this was benign tissues that were seen in the gliomatosis peritonei, and usually carry a very good prognosis on a background of a high-grade immature teratoma. So I thought this case was quite interesting to present, and we can have a discussion around it. Thank you.
In Toronto, we have Sick Children's Hospital in Toronto that does all the pediatric work. And then at Toronto General Hospital, we have the gynecologic oncologists and who rarely go to sick kids because the pediatric surgeons do most of the stuff. The immature teratomas, when you go to their rounds, they're very conservative than we are with the adults. Like a case like this at Sick Children's Hospital, she wouldn't have gotten any chemotherapy. And observed only because in children they feel they can salvage them if they do recur. The children, adults we haven't changed very much in the philosophy over the years, but children they were. I was very surprised that they would be so conservative, but they had some several cases.
Okay.
I think one of the points that I think is a similar case in terms of the staging, the pediatric oncologist said as part of their staging, they don't do lymph nodes. So how do we marry the two in terms of how we would stage a patient who is 14 as opposed to the approach from the pediatric standpoint? And two, I guess the follow-up question is, how would that impact our management, given that patients who are 1A1 are treated conservatively? If the washings were negative in the absence of lymph node biopsy here, from a gynecological oncology standpoint, what would be the discussion in terms of giving her adjuvant therapy?
Personally, that's when I have a really serious question, a really serious discussion with the patient about what her personal goals are. first of all, you're really not discussing this with a fully formed adult mind, so it's just very, very, very challenging. But at the end of the day, I like to tell people that, even when I counsel, 30-something-year-old patients, the goal is for you to be around rather than for you to not be around and leave your children or other adopted children behind because of a cancer that we could have cured. So very, very tough. Yeah.
Gynae oncs would probably manage this case rather than pediatric surgeon. And I think I would echo what Troy said. For these kind of patients, I would speak to the patient, and if they opt for conservative care, or they don't want, if you're actually offering completion surgery and they don't want something, you always have to respect their wishes, but have them under close follow-up. You bring them back to have further discussion. So moving on to the next presentation, Dr. David Samuel is a graduating fourth-year fellow in gynae oncology. He'll be presenting insights from the tubal transcriptome on carcinogenesis in women with high-grade ovarian cancer risk, a single-cell RNA sequencing analysis.
Thanks so much for that intro. Okay, so as mentioned, my name is David Samuel, and I'm a gyne onc fellow here at the University of Miami. And today I'll be talking about my thesis research, which looks at women with high-risk ovarian cancer mutations and how they're a model for some of the early events in carcinogenesis. But before I get into that, I want to first thank the organizing committee as well as my mentor, Dr. George, who guided me through this work. I have no financial disclosures to report. So for some background here, inheritable mutations in the homologous recombination DNA pathway increase ovarian cancer risk, and I've listed some of the common and less common ones here and the recommended management that several of the other speakers have spoken about today. So the recommended management for these is a risk-reducing salpingo-oophorectomy. And what's interesting about those tubal specimens is that they really provide an interesting model to look at what is the pre-carcinogenic environment of the fallopian tube. These are women that do not have cancer, but the molecular events that will lead to cancer are already in play. So some of the histological features of the tube here, I've shown a histomicrograph here. The two most relevant cells in the fallopian tube epithelia are one, the ciliated cell, which is FOXJ1 positive, and two, the secretory cell, which is Pax8 and OVGP1 positive. And the interplay of these two cells, there are histopathologic changes that occur during carcinogenesis. And one of those observations that's been made is that with BRCA mutation, with age, and with cancer, there's a loss of ciliated cells and an expansion of the secretory cells. And secretory cells, again, are the ones, these are the site of precursor lesions like sticks, scouts, P53 signatures. And the ciliated cells, they function to move follicular fluid, which contains reactive oxygen species, away from the tube, and they also are able to clear this sort of molecular damage. And the approach that we use to address this topic is something called single-cell RNA sequencing. And this technique is different than bulk RNA sequencing that has been used historically. In this technique, for a given sample, each single cell, the entire transcriptome is sequenced to a depth of between 500 to 1,000 genes. And they can then be compared to each of the other cells. So it's a different approach to RNA sequencing. So these are some of our methods here. So we had a large cohort of women that were both undergoing benign gynecologic surgery, low-risk women, as well as those with high-risk ovarian cancer mutations, such as BRCA1, BRCA2, and then also the more rare mutations like PALB2 and RAD51C. And again, these women were all cancer-free. We also, for comparison's sake, we also sequenced a couple of tumors as well. And this schematic shows our overall workflow, how the samples are processed and then sequenced. And I'll now get into some of the bioinformatic processing that was done in our studio. So this is the overall output of our study, and the plot on the left shows something called uniform manifold approximation and projection. And in this plot, each dot represents a single cell, and each of the colored clusters represents a transcriptionally unique population of cells that is significantly different from the other color clusters that are around it. So you can see that there are several labels there, and then using these canonical markers here, we were able to give identities to each of these many different clusters. So you'll see that, for example, ciliated epithelial cells can be seen here. Many of the immune cells clustered together here, CD4 and CD8 positive T cells. Some of the stromal cells like fibroblasts and myofibroblasts cluster similarly here because they share a similar function. And then the remainder of the epithelia can be seen in this region. And when we looked at the overall cell population, we found that the cell types were all well distributed amongst the different mutations, and that's shown here. So this is some of the prior data from Dr. George's lab that actually goes back about 15 years. And she was looking at the same question, but using very different techniques. And two of the main findings that she found were that, one, the tubal epithelia in women that have a BRCA1 mutation but not cancer show upregulation of multiple immune-related processes. And the other find that she had was that there was a significant upregulation of this protein called SEBPD, which is a transcription factor related to, which has multiple roles in cancer and progression of disease. So this is looking at the proportion of the different types of cells that we found for each of the different mutations. So on the left side, we're comparing low-risk women in BRCA1. In the center, low-risk women in BRCA2, and then on the right side, low-risk women with tumor. And there's a couple of key observations that we made from this slide here. So the first is that when you look at BRCA1 and BRCA2 mutation carriers, both of them have high expression of this particular fibroblast subpopulation called fibroblast DCN negative. And we see that in both mutation carriers, and that same profile is actually mimicked here in the Another finding was that when you look at the mutation carriers, those women without cancer, there's a relative immune depletion. So there's a decrease in the proportion of macrophages, CD4 and CD8 T cells, and you can see that because the dots here are to the left of that central line. And this is different than tumors. Tumors undergo immune infiltration. So you see that in the tumors, all those cells are present in large numbers. And then lastly, we see that kind of across the board for both mutation carriers and the tumors, there are certain populations of epithelial cells that are underexpressed, that are not really present. And this is something that we looked at as well in this study. So we first started by looking at the fibroblasts. So one of the great advantages of this type of technology is that once you've identified certain cell types and given them an identity, you can then select those down and do various pairwise comparisons, look for markers, and that's just what we did. So on the left side, you see just fibroblasts from BRCA1 mutation carriers. And those fibroblasts actually show several markers that are typically seen in cancer-associated fibroblasts. So cancer-associated fibroblasts are integral to the tumor microenvironment. They promote angiogenesis for the tumor, growth of the tumor cells, they dysregulate the immune system. So all of these features of cancer-associated fibroblasts are actually already present in BRCA1 mutation carriers without a cancer diagnosis. And when we looked at BRCA2, we found a similar picture as well. Not to the same degree, but there were 3 cancer-associated fibroblast markers that were present in these samples. Next, we looked at the immune environment of these BRCA mutation carriers, and one thing that we found was that, as I'd mentioned, that the absolute number of immune cells was decreased in all of the mutation carriers. However, if you look at the actual T cells and macrophages in the mutation carriers and their specific transcriptional profile, they're actually undergoing immune activation. So you see the gene ontology pathways on the left. These are all of the differentially expressed gene pathways, and many of them are related, of course, to immune function, comparing mutation carriers and wild type. But this mechanism of immune depletion, but also simultaneous activation, is not occurring through what's called T cell activation, T cell exhaustion. So T cell exhaustion is a well-described phenomenon in tumors where T cells are present within the tumor, but have kind of a deactivated phenotype. So when we looked at several known T cell exhaustion markers shown here, we saw that the tumors showed them at high levels, but none of the mutation carriers showed a T cell exhaustion phenotype. So again, pointing to the microenvironment of the fallopian tube and some of the early carcinogenic changes that are taking place. And then next we looked at the epithelial subgroups, and what we were able to do was actually find several different types of epithelial and ciliated cells, each of which was characterized by different markers. And you can see the markers that are highly expressed in red and the ones that are less expressed in blue here. Now, each of these different groups had a different sort of a phenotype, but still, when we compared BRCA1 and wild type, we found that particular cell groups had, an unusual phenotype. So, one was the BRCA1 ciliated cells. Although these cells are ciliated and function, to move cilia and follicular fluid, they had several gene ontology pathways that were associated with immune activation. So again, actually echoing what Dr. George had found almost 15 years ago, that the tubal epithelia has an upregulation of these immune processes. When we also looked at non-ciliated secretory cells, cells that should be just having a pure epithelial function, when you look at the mutation carriers, all of the gene ontology pathways are related to extracellular matrix, reorganization of the extracellular matrix. So these are all features of the epithelial to mesenchymal transition, which is another feature of carcinogenesis, that those cells that rest along the epithelia are becoming mesenchymal and then eventually the basement membrane and metastasize. And then lastly, we also found two particular subgroups of secretory cells that were just limited to wild-type patients and were not found in the mutation carriers. So the specific significance of these cells is not clear yet, but they do have a stemness phenotype. They express SparkL1 and SOX5, and they also have several mesenchymal markers as well, which they should not. So the fact that they are just limited to wild type and not present in mutation carriers, this could be a number of things. This could represent perhaps a transitional state, and if that transitional state amongst the epithelia is lost, this might in some way impact carcinogenesis. But this is definitely something that needs further research. Now, to corroborate our findings, we then performed a laser capture microdissection. So our analysis until this point, it was mostly in silico. So what we did here is we used fresh frozen paraffin-embedded tissues to actually dissect out the tubal epithelia and then see if we could identify some of the same genes that were highly expressed in our in silico analysis. And we were, in fact, able to do that. There were several genes shown here at the bottom that were identified in this data set, as well as with our single-cell RNA sequencing analysis. So in conclusion, using a single-cell RNA sequencing approach, we were able to identify several different pathways involving the immune compartment, the stromal compartment, and also the epithelial compartment that reveal some of the early carcinogenic mechanisms that are in play for these women that we are observing and offering conservative management. And this type of information, the mechanism of and precursor lesions in ovarian cancer have already been known for many, many years. But studying them via this approach allows us to understand their transcriptional signature in a much, much more granular way. And this type of information can be used to apply and refine ovarian cancer screening practices. So if the high-risk tubal transcriptional signature can be identified in someone with a BRCA1 mutation, the hope for the future is that we'll be able to do this and identify it in a woman who perhaps has a high-risk family history or has a BRCA1 mutation to determine if they have cancer or not. Thank you for your time, and I'll take any questions.
There we go. Okay. Okay, so for my next talk, I'm going to talk about novel agents and future directions in ovarian cancer. This one should be more on track. Again, I'm boring. I think Dr. Alvarado was very good at sort of going through the historical part of like where we came with chemotherapy in addition of carbo with less toxicity, Taxol, taxanes, Scott Rock 96, and then Doxil, and not really much happened in those years. Those were important developments, but in the last 15 years, we've had a lot of action, okay? And I'm going to tell you that I'm not going to be talking about PARPs. I think you guys have been PARPed to death today. Thank you, Dr. Schlembrick. But there's been very significant advances recently, and I'm going to talk about FDA approval of mirvetuximab, and also another folate receptor alpha target, which is Cytolux, which is actually used for, this was approved for near-infrared imaging during debulking surgery to help identify additional tumors that you may not have found. So like I said, it's a very hot target right now, folate receptor alpha. It has a wide potential for uses, including CAR T, but we're going to focus on antibody drug conjugates as well as for treatment therapeutic antibody drug conjugates as well as the immunofluorescence. So SORAYA was the first positive folate receptor alpha biomarker-driven study. It was a single-arm trial looking at the efficacy and safety of mirvetuximab sotorastat in patients with folate receptor alpha positive platinum-resistant ovarian cancer. And they took patients that were folate receptor alpha positive, platinum resistant, either ovarian, fallopian, primary peritoneal, pretty standard. They had to have had 1 to 3 prior lines of systemic therapy, no more than 3. Platinum resistance was defined as, within 6 months, recurrence within 6 months of last platinum-based chemotherapy. And they were excluded if they had ocular problems, so similar to the TIVDAC that we talked about earlier. Primary endpoint was overall response rate, and the secondary endpoint was duration of response. And it's given every 3 weeks intravenously. And so you have to remember that this is a super difficult population, right? This is where most of the research is focused, like where nobody's doing platinum-sensitive recurrent trials, right? Because we can treat those. This is the patient population that we can. And half of these patients had stable disease. Many had partial responses. And on the investigator assess, there were 5 complete responses. And on a blinded independent review, central review, they determined that there were 6 responses in this patient population, a little bit over 100 patients or so. And the overall response rate was 34%. And when you look at duration of response, it averaged around 7 months. And the time to first response, these patients were getting every 8-week CT scans. So the time of first response was right around that first imaging study, first or by the second imaging study. Most of the responses had already been appreciated. As far as treatment-related adverse events, most were low-grade and reversible ocular and GI events. There were serious greater than or equal to grade 3 in 8% of patients. Adverse events did lead to delay and dose reduction in 32 and 19% of patients respectively. And there were 7 patients discontinued because of those effects. 1 death was recorded, possibly related to the study drug. a patient that died of respiratory failure, but on autopsy there was no evidence of immune-mediated pneumonitis. So mirvetuximab demonstrated clinically meaningful anti-tumor activity in patients with folate receptor high platinum-resistant ovarian cancer patients. That's greater than 75% expression. 32%, including 5 or 6 if you do the independent review, and a median duration of 7 months, and low-grade reversible ocular and GI events were most common. And so this got FDA approval in November of 2022. Marisol was another study that was looking at mirvetuximab compared to dealer's choice chemo. So investigator choice chemo versus MIRV. And there were 453 patients in the study. Again, they were platinum resistant less than 6 months since the last platinum chemo. They were greater than or equal to 75% expressivity in the tumor in the viable tumor cells. They were high-grade serous, and their primary platinum refractory disease was excluded, though, and that goes with a lot of clinical trials now. They don't want to include the worst actors, and I think that's a little bit of bias in the study. 1 to 3 prior lines, prior BEV and PARP were allowed, and patients with BRCA mutations were allowed. And so they either received the mirvetuximab 6 milligrams per kg every 3 weeks, as was with Soraya, or they either got Taxol, Doxil, or topotecan, and the investigator's choice, they was stratified by the choice of chemotherapy as well as the number of prior lines. And primary endpoint was progression-free survival, and secondary endpoint overall response rate, overall survival, and patient-reported outcomes. So when we look at the progression-free survival as assessed by the investigator, there was a significant reduction in the risk of progression with the mirvetuximab as compared to the chemotherapy. And overall response rate in this study for MIRV was 42%, and 12 patients had a complete response. So 5% of the patient population had a complete response in what would otherwise be incurable disease. You see where we were is 0 complete responses. So, the overall response difference was 26%, and the odds ratio was 3.81. When we look at the actual reduction in tumor, we go through this RECIST and we make an sum of largest diameter. When they compared all the target lesions and looked at the maximum reduction in the tumor, you had an 80% reduction in tumors with the MIRV versus 55% reduction with chemo. And then overall survival, again, was statistically significant. There was a huge reduction for this patient population in the risk of progression or the risk of death from disease at 33%. So there are other antibody-drug conjugates. I'm sorry, just click them all out. There was another study looking at a different antibody-drug conjugate that had a different payload. It wasn't a microtubule disruptor like MIRV. But this was looking at luveltamab, tezevibulin, and I still don't appreciate the way people name these drugs. And try and name the target there, yes, the payload. So there was again seen a very significant overall response rate of 31%, and these patients were. It was a phase 1, so they were looking at dose finding. They were randomized 1-to-1 to either a 4.3 milligram or a 5.2 milligram dosing, and it was significantly more toxic though than the Elahere. 61% of patients had to be dose reduced because of primarily neutropenia. There was febrile neutropenia in 2 patients. They determined here that they need growth factor support with this regimen. And the median duration of the AEs was about 8 days. Patients had arthralgia, they had peripheral neuropathy, This was less than with the mirvetuximab, which is around 12% peripheral neuropathy rate. And then the grade 3s leading to discontinuation in 3 patients were because of fatigue, neuropathy, and sepsis. So this went to phase 2, and this drug went to phase 2, looking at patients that were expressing folate receptor alpha. They were either given a loading dose of the higher dose followed by the lower dose, or given the lower dose. Patients were allowed to continue on the optimized dosing regimen once they figured out which one was better. Let's see. So we've talked about the antibody drug conjugate therapeutics. So let's talk about the fluorescence imaging. So this is a study looking at infusing Cytolux at least 1 hour prior to the surgery. And the patients were planned on undergoing debulking surgery. And they either did white light, like normal OR lights, identification of tumors and debulking. And then after that was felt to be a complete cytoreduction, then they would put the near infrared and they would look for flashy stuff. Okay. And they determined that they were able to find, in 27% of patients, they were able to find additional lesions that they wouldn't have found otherwise if they didn't use the Cytolux. So in a subgroup analysis, they confirmed that folate receptor positive ovarian cancer underwent interval debulking surgery, had additional lesions in 40% of the patients. And then half of the surgeons said that using this would alter their surgery as opposed to just doing standard white light debulking. So other agents. What about HIPEC, right? HIPEC's a big hot topic right now. We have the HOT study that's ongoing, that's open now at UM. This is a very interesting study because in the past, it's either been at interval cytoreduction, primary cytoreduction, or recurrence with cytoreduction, right? This is looking at, this study, let me just put the schema up, it'll be easier. This study was looking at giving sort of induction chemo. Basically, you give the second-line chemo, right? You give the second-line platinum-based chemo. You do the surgery afterwards. And in the surgery, they were randomized to either HIPEC or no HIPEC. I like no PEC. And then just standard care maintenance therapy. So no chemo after the debulking, which is kind of a different paradigm from what we're all used to, right? So the primary endpoint was overall survival. 35% of patients had received bevacizumab up front, which we don't typically do in the upfront setting. And then 87% of patients had complete cytoreductive surgery after 6 cycles of chemotherapy, which that part makes sense. 30% of the BRCA patients in each arm were BRCA positive, and patients got part maintenance, and 22% of HIPEC patients and 70% of no HIPEC, or no PEC. Okay. Oh. There we go. Okay. So when you look at the overall survival, it was dramatic. And when you look at the number 54 for overall survival, you're thinking this is a primary treatment, right? This is primary treatment, because those are the type of numbers that we kind of expect from the historical data of surgery followed by chemo, or chemo with interval cytoreductive surgery. But this is in the recurrent setting. In the recurrent setting, they had overall survival of 54 months with the HIPEC versus 45. So there was a 31% reduction in the risk of death if you gave HIPEC in this manner in the recurrent platinum-sensitive setting. Grade 3 morbidity was 20 versus 40%. Deaths were 1.4 versus 0. And renal toxicity, once they realized they weren't giving sodium thiosulfate, improved to be equal among the groups. What about rare tumors? Let's talk about low-grade serous. This is a obviously, when you talk about low-grade serous, you see Gershenson. So, of course, he was the first author on this study that looked at patients with recurrent low-grade serous carcinoma following initial diagnosis of ovarian or primary peritoneal low-grade serous or serous borderline. They could have an unlimited number of previous therapies. They had to have measurable disease, according to RECIST, and they were randomized 1-to-1 to trametinib versus standard of care single-agent chemotherapy. And we all know that trametinib is a MEK inhibitor. So there were 260 patients, and the median progression-free survival on the patients that got trametinib was 13 versus 7.2 months on patients that got standard of care chemo. And the median overall survival was significantly improved at 37.6 months versus 29, favoring the trametinib arm. And the hazard ratio for death was 0.76, so a significant reduction in the risk of death with the use of trametinib as opposed to chemotherapy. Oh, this one was shorter. This one's shorter.
Okay. Yeah, thank you very much. And so we move on to our last session, which is Stump the Professor with Dr. Vikas Chatrani. Dr. Vikas Chatrani is a gynecology consultant working in Barbados and also a very active member in the CGCS. So I'll hand you over.
So guess who's going to be the professor? Thank you, Vishal. Money heist. Yep, the professor. Okay, good. Well done. So you passed that one already. So she's a SC, 34-year-old, power naught +1, who presented to us sometime in April. I think it was the 18th, with the last menstrual period of the 11th of April. Actually, that's how she presented to her gynecologist. And her complaint was that she was having this heavy menstrual bleeding and dysmenorrhea after recovering from COVID a year before. So, we blame COVID for everything, yeah? And she was seen by her gynecologist and managed with the oral contraceptive pill. She was given microgynon at first and given a presumed diagnosis of endometriosis. So that was based on a normal ultrasound, just which showed polycystic ovaries. The dysmenorrhea persisted. She called her gynecologist and she said to just tough it out. She switched her to Vizan, then Femian, and then Yasmin. So she basically went through a whole bunch of oral contraceptive pills trying to control her endometriosis. You have to understand that theater time is a challenge in the region. So, traditionally you would have done a diagnostic laparoscopy and confirmed the diagnosis. She treated her as a presumptive diagnosis. Anyway, she switched her gynecologist, and that's when she finally got the ultrasound that I mentioned there. Otherwise, there was just an in-office ultrasound. 8 months after her initial presentation, that was December 2022, and having switched to Yasmin, which she actually did get some improvement, her heavy menstrual bleeding returned and never stopped. And she presented to the accident to the emergency department at the Queen Elizabeth Hospital, that's the primary hospital in Barbados, complaining of abdominal bloating, decreased appetite, and an increase in abdominal pain. And a second ultrasound was performed, so this is her second ultrasound. And they gave us the clinical history. 34-year-old lady, lower abdominal pain, left side more than right. She had some bleeding, no discharge from the vagina, so they were querying endometriosis again, and probably potentially a ovarian cyst. And the uterus was normal, endometrium, homogeneous and linear. They saw a well-defined endometrial myometrial junction. I'm not sure why the ultrasonographer wrote that. The left ovary was enlarged and well circumcised, and they described it as a solid cystic mass with moderate internal vascularity. The cyst measured 5.3 by 5.3 by 3.4. Right ovary was normal in size. No mention of the polycystic ovaries that we saw or heard about from the previous ultrasound. And kidneys. So they just put indeterminate complex left ovarian mass. This is just the clinical history for the patient. She was a gravida 1, power naught +1, just had a miscarriage prior. Menarche was at 9 years of age with regular cycles occurring every 28 days with 7 days of menstruation. Had heavy menstrual bleeding and dysmenorrhea described as 10 and 10 in severity, managed basically with NSAIDs. Her last normal menstrual period, as I told you, was the 11th of April, and she was diagnosed with polycystic ovarian syndrome in her teens. But that, you know, based on the Rotterdam criteria, you needed 2 out of 3, and she only basically had 1 scan showing polycystic ovaries. There's no mention of any excess androgens. Her contraceptive use was as previously stated. Pap smear 2021 was normal. And she wasn't sexually active for more than a year, and no history of any sexually transmitted infections. No chronic illnesses in her medical history, no previous surgeries, wasn't taking any medication apart from the pill, and she had no drug allergies. She lived with her dad, had a history of cigarette smoking, but no significant alcohol use. And there was no family history of breast, gynecological, thyroid, or colon malignancies in her immediate family. Her father was hypertensive and diabetic and on with kidney disease on renal dialysis. So I thought mention that just to give you an idea of her social circumstances. And her brother, who was a banker, was 44 years of age. He was epileptic, didn't drive because he had a car accident during one of his seizures. And this was added there because it may add some value later on in the presentation. Following this, when she visited the new gynecologist who saw the ultrasound with the ovarian cysts, he requested a CA125, even though the ultrasound just said indeterminate ovarian cysts. It was elevated. It was what, 51? Normal is 0 to 35. And findings. What do you think is the diagnosis, Professor? Right, so basically unremarkable exam. She just had tenderness over that point where the cyst was, complaining of 10 out of 10 excruciating pain. Now you have to understand our accident in the emergency department in Barbados. If you're going to the A&E department, you're looking to spend 2 days there. So for her to have pain, to go and sit down, wait a day, then be seen, then probably take about 8 hours to get an ultrasound scan, and then another 8 hours to get a report. This had to be some significant pain for her to go into the A&E department to spend 2 days there. So it's going to come in a little bit further. It's 32.1. That's the ultrasound report. No comment on Dopplers. That's a good question, though. Yeah, correct. They said vascular flow in the periphery, right? Something that was moderate internal vascularity. I'm not sure what that means, but yeah, there is blood flow. You're making a diagnosis? Yeah, yes. Well done, well done. You're picking up stuff. That's good. So I actually use the resident's presentation for the initial part. The gynae presentation you'll see as it comes there. So just one idea. I mean, she's planned for a laparotomy. This gynecologist has booked her for surgery. What do you think? Common things, common. A year. So COVID, April 2022. And then she saw her gynecologist in 2023, April, with the history of heavy periods, painful periods, and she attributed it to COVID. I mean, everybody attributed menstrual disturbances to COVID, right? And even though the initial research came out saying, oh, there was no association, we saw follow-up research that COVID was associated with missed cycles, heavier cycles. No, not investigated. Endometrial biopsy. A 34-year-old paranoid +1 with regular periods on the pill. Huh? Endometrial biopsy? She was having regular cycles. She was just getting pain. $34? Yeah? Well, the guy...
Collectively, like a marrow issue as a result of her COVID. You know, she could have hemorrhagic cyst, it could be endometriosis, she could have granulosa cell tumors. That would explain why she's got hormonal irregularities.
But remember you mentioned something about the endometrium and I thought it was
Homogeneous
homogeneous and
I don't mean
It's a
anything.
base was normal, but
It's
still
a
it's
phase.
an ultrasound.
Is that ultrasound? You can miss
This
it.
is a room of gynae oncologists.
So all the ultrasound shows is that if there's something there, there's not ultrasound evidence of
you said an
endometrial invasion.
endometrial biopsy, but I mean, a DNC to me.
Hysteroscopy and biopsy.
Wow.
Just from past experience, young patients, PCOS, so we're seeing people
I
in
know
their
you get people with
20s
heavy
and
bleeding,
30s.
you can't do a therapeutic DNC or something like that.
No.
Okay. Alright, Darren? Yeah, man.
Let's do it.
I thought the cyst is causing her pain. Alright, that's the ultrasound, sorry. Endometrium, homogeneous and linear, well defined. Anyway, let's see what the gynecologist did. I know, that's good, that's good. So the pre-op diagnosis was endometriosis with endometrioma. She underwent a laparotomy and had an ovarian cystectomy and a removal of a right paratubal cyst with biopsies of the right and left pelvic side walls and right ovarian surface with the thinking of this is endometriosis. A laparotomy. That's her gynecologist that did it. She have a cyst, indeterminate, CA125 of 51. He said you're going to take out endometrioma. Laparotomy. So he said fan of steel incision, laparotomy. Yeah, pre-op diagnosis. But intra-op, that's what he was thinking, right? When he saw it enlarged ovary. It was mushy and full of blood sort of thing. That's what he thought. Endometriosis lesions on the side wall, so he took it out. Yeah? Okay. So the histology. Sections of the ovarian parenchyma exhibit infiltration by a neoplasm which exhibits complex viloglandular growth and hierarchical branching. The constituent cells contain hypochromatic pleomorphic nuclei. Mitotic activity is brisk. Inclusive of atypical forms, extensive necrosis is also present. A rim of normal ovarian parenchyma is also present. I'm going to repeat that again. A rim of normal ovarian parenchyma is also present. A paratubal cyst is identified histologically. Sections show a portion of the cyst wall which is lined by ciliated columnar epithelium with focal papillary projections. The features are inconsistent with a paratubal cyst. Biopsies have been examined in total. Sections show hemorrhagic fibroconnective tissue which contain benign endometrial type glands and stroma. The features are typical of endometriosis. The biopsy has been examined in total. Sections show portions of fibroconnective tissue with infiltration by cells morphologically similar to those described in type 1. So specimen 1 is a left oophorectomy specimen, and that's the one that has the brisk mitotic activity. Specimen 2 is the paratubal cyst, benign, right? The paratubal cyst. Specimen 3, pelvic side wall disease, endometriosis. Specimen 4, right ovarian surface disease. So remember, it's the left ovary he has oophorectomy here. I think it was a cystectomy, but we'll get to that. Right ovarian surface, endometriosis. And this is a little bit confusing, right? The left pelvic side wall described in specimen 1, morphologically similar. So is he saying that there's tumor on the left pelvic side wall? Well done. So the gynecologist then calls the gynae oncologist and says he has this lady who had a oophorectomy and resection of deposits, some endometriosis. Okay, very good. That's one. So that's the plan. Pathology review. I like that. I think they had suggested something in their report. Immunohistochemistry. IHC. Given the presence of endometriosis elsewhere in the pelvis, the differential diagnosis include endometrioid adenocarcinoma. Involvement should be ruled out. Immunohistochemistry. So I think that was requested. I can't remember what the slide shows. So anything else? All right. So imaging. So you think like a staging what CT? Okay, that's a very good one. Anything else? So it's saying the pathology confirmed. No. So if you say the pathology confirmed ovarian endometrioid adenocarcinoma, she needs endometrial biopsy. Yeah. So you're going back to the endometrial aspirate. Okay, well done. Anything else? So the gynecologist wants to know if to send her to the gynae oncologist. Is there further surgery, or is this because there is in the literature reports about endometriomas undergoing endometrial transformation? Yeah. Darren, slides back again. I actually discussed this with Ian Harley because they were wondering, does she need further surgery from a gynae onc point of view? And that rim of normal ovarian tissue, but I like the thing about doing the biopsy of the endometrium. Would you still do further surgery on her? Right, so that is if the left ovary is out. So I thought it was a cystectomy, but the specimen says left oophorectomy. So say if that ovary is out. You're happy? All right. So I think the immunohistochemistry comes next. But so they were trying to work out, should we send her to a gynae oncologist? The answer, we all agree yes. A staging CT, maybe? Yes. No? But re-exploration, what do you mean by that? But you need imaging. You still want imaging, right? You still want to know what you're going looking for. Lung mets on a 34-year-old? Crap. These are oncologists in the room. Any value in a post-op CA 125? No? Okay. It was 51, right? So is there adequate treatment? Does she need a PET scan? Not yet? Okay, just checking. And then the discussion about completion surgery. If you were to do completion surgery, say this is an ovarian primary. So he's saying take out everything. So, yeah. No, +1. +1 is a miscarriage, termination, anything like that. Darren, slides back. And then if you're going to do completion surgery, as Paul is saying, take out everything, do you then refer her to a fertility center for oocyte donation? Yeah. All right. So say it comes back showing grade 1. So this is a CT scan. A lot of things there. First thing up. Few scattered lung nodules are seen in both lungs. The large lower left measures 0.5. Everything else, uterus, ovaries, appear normal. I don't know what that means. Trace the pelvic free fluid, likely physiological. Small volume periaortic lymph nodes are noted, 0.7 by 0.5. Doesn't meet size criteria. No significant adenopathy. Bowel, everything looks normal. So apart from these 0.5 centimeter scattered lung nodules, it was a CT chest, abdomen, and pelvis. They wrote small bilateral lung nodules. Early METs cannot be ruled out. Recommend follow-up CT. And they actually said somewhere 4 months. Go back. So, Matt, they will call that a goat mouth in the Caribbean. When you say something and then you speak it into existence. So you said something. So they call that lung METs. Now, yeah, you were asking something, Tim? The uterus and ovaries appear normal. Trace of pelvic free fluid, likely physiological. 0.7 by 0.5. Nah, size criteria. Yeah, she had surgery. Endometriosis. Yeah, she had an immunohistochemistry done. It's going to pop up shortly. It said endometrioid adenofigo grade 1. And it went through to the markers. You're all familiar with these guys. CDX2, ER, PAX8, and positive, 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 negative. So the combined morphology and immunophenotype are indicative of adenocarcinoma of gynecological origin. And in this setting, ovarian endometrioid carcinoma, FIGO grade 1. So he's saying endometrial biopsy. All right. So, Professor, is there adequate treatment? PET scan, not available locally. Interval CT chest, yeah. Completion surgery again. Oophorectomy, biopsy of the ovaries. Oocyte donation. So what I have here. 4 days prior to presenting to her gynae oncology consult, while at the tail end of completing oocyte donation, because the gynecologist actually referred her to the fertility center before he sent her to the gynae oncologist. She has a history of going to the... Yeah, we have a fertility center. So we have a very good fertility center there, and it was just at the end of COVID. Yeah, no, they don't, and they were offering a special because they depend on tourism, medical tourism, because we didn't have people coming from North America and Europe. They were giving specials on oocyte donations. So this was a fast track, 50% off. You can get your eggs stored for another day. Anyway, so she has a history of going to the bathroom at 3 o'clock in the morning. Couldn't move her right arm or her right leg. She fell. Face felt droopy on right side of face. She closed her eyes, couldn't talk. After minutes, was able to shout and raise her dad. Remember, her dad's the one that's hypertensive, diabetic, on dialysis at home. And her brother's the one that doesn't drive because he's had seizures in the past. So she presented again to the accident emergency department at the QEH facility. Is it a hemiparesis that resolved after a few minutes? So why the fall? Right? You're scanning her head? So there was some talk about it being psychological, and it's a call for help, because when she reaches the accident emergency department, she's completely normal. Shit. When you say scan it, you mean psychiatrist? CT. All right, y'all like this investigation. Completely resolved. She True embolism? No? Migraine. Paraneoplastic syndrome. Okay. So we're eliminating psychological. Okay. Seizure. The family history of seizure. Is this a seizure? Her brother's epileptic? No? Okay. OHSS, you know what that is? Ovarian hyperstimulation syndrome, where you get electrolyte disturbances from ovulation induction. No? Okay. But nobody witnessed this, This is her telling us she had weakness, her face. Okay. All right. Hemiplegic migraine. So when we bring this up, apparently she saw a neurologist in April when she was having the dysmenorrhea and menorrhagia, because she had a headache that would not go away. And he actually diagnosed her with cervical headache. I had to Google cervical headache too as well. I can't remember what it said, but I guess a headache that doesn't go away. So TIA, brain lesion? TIA, right? But so apparently hemiplegic migraine is mimic a TIA. So the same thing. Okay. So investigations, CT. CT brain. Small ring enhancing lesion in the right frontal lobe. Rule out metastases. That was in A&E that she had it. So remember, October 2002, I have a normal ultrasound. Just saying. She hasn't even seen the gynae oncologist yet. So it's 4 days before. Looking at probably within the 6-week window, because she went to get her oocytes. So are you happy with that, though? Small ring enhancing lesion. Is that a MET? It's a CT. She has an MRI. Yeah, well done. So she goes to the gynae oncologist. And that's where her BMI pops up now, 31.5. So I told you 32. Abdomen is flat, so you were asking examination findings. That's good. It was heel, fan, and steel scar, soft, non-tender, no organomegaly, no masses, vaginal examination, normal, breast exam, normal, thinking, prof, any further investigation? Y'all still talking about this endometrial biopsy, dude? Planned surgery, neurosurgery, joint surgery, Because apparently the gynecologist called the neurosurgeon about this brain lesion and asked him about doing it. He was talking about doing completion surgery and taking out that brain lesion at the same time. He got excited, the neurosurgeon. Yeah, yeah. And then if it is, you're saying METs, then you're talking about chemo. Endometriosis to the brain. I like how y'all are thinking. All right. Complete chemo radiation. Is it stage 4? Palliative care? Okay. I like that. That sounds like the IGCS lecture they had out there when you start off. Okay. So this is her ultrasound at the gynae oncology visit. Uterus normal, endometrium mostly trilaminar. There was some appearance of an irregularity at the fundus that looked like a polyp. I'm not sure if y'all can appreciate it. Remember the last one was saying that the endometrium was normal. So investigations, we do labs. Pap smear. Last one was in 2021. I'm just asking. 2000. Okay. Endometrial biopsy. Yeah. Other. Is it a polyp? Okay. Let's see. So she had a pap smear, an endometrial biopsy was performed. Pap smear was normal, blood investigations were normal. And let's read the endometrial aspirate, not the DNC. 3 mils of fragmented tan tissue. Biopsy has been examined in total, consists predominantly of blood. Embedded there are fragments of the endometrium which contain crowded irregular glands with scant intervening stroma. The glands are lined by stratified columnar epithelium with round nuclei and prominent eosinophilic macronuclei. Mitotic activity is apparent, inclusive of atypical forms. This is consistent with complex atypical hyperplasia. He makes a comment. The history is noted. Given the presence of endometrioid adenoma of the left ovary, spread from an endometrial primary with secondary involvement of the ovary should be considered in the differential. Yep. Mm-hmm. We do. So they don't do. They have. So this lab actually has 2 pathologists, and they usually document that they have inter-thing observation. So are we changing the thinking based on that? No, Pipel, endometrial aspirate. Yeah, man. Remember, it wasn't a hysteroscopy. If she getting put to sleep, she wants. And yeah. Slides again, Darren. So again, the discussion that came up, are we having surgery on this lady again? Are we talking about stereotactic radiation to the brain because she had symptoms of it? They put her on an anti-epileptic. The neurosurgeon, so I think he put her on steroids too as well. Are we dealing with endometrioid carcinoma of the ovary with the lung and brain mets? Remember those investigations that we requested? Those FBC with full blood count, urea electrolytes, LFT, CA125, hemoglobin, glycosylated hemoglobin. So we had the MDT meeting. Neurosurgery was pushing for joint surgery. Yeah. We then gave her the possibility of going overseas to get that dealt with radiation-wise versus doing surgery, which has its increased morbidity. And we went in. She had blood-stained peritoneal fluid, a bulky uterus, 12-week size. Ovaries were enlarged and multicystic in keeping with recent ovarian stimulation, loosely adhere on the posterior aspect of the uterus by the uterosacral ligaments. The left ovary, so remember it said left oophorectomy specimen? It was a left cystectomy specimen with a rim. Adherent to the left uterosacral ligament. So when they do oocyte retrieval, usually when those ovaries become multifollicular, they drop into the pouch of Douglas. And then they do a transvaginal approach where they puncture through the posterior fornix and hit each and aspirate each of those follicles to get a oocyte. So you can commonly see this after egg retrieval. Omentum looked grossly normal. I think we went back into the same Phanon-Steel scar. No obvious lymphadenopathy in the pelvis. So I think what did they do? They took it out. Crap, they took out everything. They took out her cervix, her uterus, her ovaries, so TAH, BSO, infracolic omentectomy, and probably washings. For size reference, I think. Yeah. They have measurements on them. Don't they have measurements here, Matt? 0, 1, 2, 3, 4, 5, 6. Yeah. Hold on. Estimated blood loss 500. Relatively uneventful post-op hospital stay until day 3, where she started experiencing irretractable vomiting. Yeah? Abdomen wasn't distended, soft, tender in the epigastrium. Bowel sounds were normal, flatus, no stool. So we had the gynecologist, who seemed to be a family friend, doing rounds in addition to the gynae oncologist. So he calls the general surgeon. We thought maybe NSAIDs, even though she was on an H2 antagonist, the epigastric tenderness, the plan was to stop the NSAIDs, give her opioids and acetaminophen for pain relief. He said, if you're thinking something acute, that she's vomiting, you scan her abdomen. So they did they ordered a CT. Yeah, CT was requested, oral and IV contrast. Geeks. So the clinical details: 34-year-old who underwent an ovarian cystectomy in February. I think I skipped a slide. Yeah, ovarian cystectomy in Feb for what was thought to be endometriosis. Have endometrial. I know there's clinical details on the histology. Subsequent CT showed some lung nodules which didn't meet size criteria, so surveillance in 4 months was suggested. There was an endometrial aspirate which revealed endometrial atypia with a comment to consider primary endometrial CA in previous cyst histology. Had a seizure. MRI suggests a brain met. CT done. So that CT actually now showed size-specific para-aortic nodes. Okay. Which was not there before. That's fine. So we're accepting a para-aortic node as reactionary? Okay. So this is her histology. I'm just going to look at the summary down here. But it confirmed endometrial carcinoma, now grade 3. Mets to the omentum. And I think you have to read the microscopic description to appreciate that. Sections of the endometrium showed scattered masses of an endometrial carcinoma grade 3 in an endometrium that is otherwise secretory. The growth pattern is solid with very minimal gland formation. Direct invasion extends to less than half of the myometrium, but lymphatic permeation is extensive, extending through the full thickness of the myometrium. Tumor is not seen at the serosa. The nuclear pleomorphism, nuclear enlargement, and nuclear, as well as the frequent mitotic figures, the tumor is not seen in the endocervix or at the ectocervical and radial resection margin. Both ovaries contain corpora albicans, follicular cysts, and odd simple benign cysts. Foreign body reaction to suture material is seen in the left ovary in keeping site of previous surgery. No evidence of any malignancy. I'm assuming they're talking about the ovaries, right? Both fallopian tubes are microscopically unremarkable and negative malignancy. Sections taken from the omentum show metastatic carcinoma, some of which appear to be in lymphatics. That's weird. No, because the CT prior. Remember, we're dealing with. Right. You should do nodes. Yeah. Yeah, good point. Yeah, brain mets. So she was counseled on the diagnosis of metastatic endometrial cancer and referred for chemotherapy. Suggested for MMR protein testing. She actually received systemic chemo with carbotaxol and Keytruda. PET scan showed brain lesion, front enhancing lesion. She actually went to get stereotactic, sorry with his spelling, for the brain lesion, and her PET post that treatment was negative. I know, from a long time. It's good. So now that she had a PET 1 year, just about 2 weeks ago, which now shows her para-aortics again to be lit up. So you were asking me the size. This is a year later. Para-aortic adenopathy with retrocaval and aortocaval masses measuring up to 1.6 centimeters. The largest one, 3.5 centimeters. By 0.5. And we thought maybe reactionary, maybe. Yeah. And she got, do I have it? She responded to chemo, but the brain lesion didn't shrink. Where do you see that?
But
I mean,
I think
those
all
start
immune
with-
checkpoint, like
Yeah.
all immune checkpoint does have some degree of,
Yeah.
but chemotherapy is the carbotaxol doesn't really.
Yeah, so what was interesting about this case is that her gynecologist was very involved with her care. So, well, this is the second one, not the first one. The first one told her she actually said just tough through it and just kept switching pills on her. So when the second one got involved and he said, well, look, you're having this much pain, let's go in and take out that ovarian cyst or whatnot. And then he started involving us from the gynae oncology team because, for a year. Yeah.
To hormonal, you know that is something malignant.
And she had a follow-up, I'm sure she gets like every 3-month MRIs, right? Of the brain.
So she's now under the care of the oncologist. They gave her steroids. So she's getting a PET, and I'm sure she's getting MRI. Well, when we got back the PIPEL, and the thinking was that, this may be a primary endometrial with an ovarian spread, that she would benefit from completion surgery. But we thought it was palliative if we thought that brain lesion was metastatic, and then the small lung nodules too as well. So at the end of the day, it was to help confirm what pathology we were dealing with and then debulk it at the same time. So what we look at is anesthesia, right? So anytime, and I mentioned this earlier, theater time is precious. So, when she mentioned after the PIPEL, we should have probably done a hysteroscopy. I know they can be done in office and whatnot, but you're looking at just utilizing your theater time to the best of its ability. So bringing in somebody for things like EUAs and stuff, there is value in it, but we hate to do diagnostic procedures when we have like one list a week and a waiting list. No, I mean for the hysteroscopy. So diagnostic and therapeutic would have been, but it doesn't address the ovarian pathology. Yeah, correct, yeah. The biopsy to within 6 weeks. That's weird. Her disease is so aggressive. Yeah. No, but you remember the ovarian cyst IHC came back as grade 1. But remember he said complex atypical hyperplasia, but in view of the ovarian pathology, it was only 3 mils of tissue that came back, so it was probably 3 pulls at the PIPEL that she got. Yeah. And then if you read the histology, it said a lot of secretory endometrium and like masses of endometrial cancer. So she actually came over from the gynecologist with the mindset that she had to get surgery. And then when you threw out that you have to test her endometrium, she's like, is that going to delay things again and whatnot? So I think the same visit is when she had the PIPEL, the PAP, everything done one time, the scan. Because in her mind, she's preparing. She just did oocyte retrieval because she knows that she's going to get. And I remember that she had that seizure 4 days before the gynecology visit. She was talking about a Beyonce concert in August, and we were in April. Is she going to live to see that? She has tickets. So her life just turned completely around, and that's why having oocytes donated, she just wanted to live. So that's why she was choosing life over fertility. She's like, take everything out. All right, thank you. I'm sorry to make it so whirlwind, but keep you guys entertained.
So some of us do. No, single lumen, like a 6 French. So both Matt and I put in ports. So here it's depends on people's training. So we put in ports, and some of our colleagues don't, and the general surgeons put them in, and then really mostly the interventional radiologists can put them in, and it depends on the service and whether they have the ability to just get people in quickly. So We'll refer to the IVR people often, or just put them in ourselves. Depends on the cancer. Yeah. Yeah. Every 8. Every 8. At a stretch, I flush it every 8. All right, so I guess I'm the wrap-up show. So I'm going to keep this really brief. Yeah. Couple of things I wanted to say and thank you, and then before some closing comments. So some important thank yous. First of all, thank you to the CGCS itself and to the officers of the CGCS and to Vikash and Raleigh and Dr. Butler for having us here. Also, it's great always to have the elder statesmen of the CGCS continuing to give us context and history to what we do and why we do it. So thank you, Dr. Gopi Singh and Dr. DiPetrillo, for being here and for making the trip down from Canada. I want to thank all of the speakers who spoke today, especially the folks that are not here that may have had to leave. Dr. Sino went to a precision meeting that is having up in Fort Lauderdale. But for all the speakers in the room, we sincerely appreciate your input today. And to our fellows, Dr. Mercadal and Dr. Samuel for presenting their thesis work. I would like to give a very personal shout out to whom I think is the hardest working physician in the room today, which is Dr. Halliday. Yeah. Who kept us AV savvy and working well for all the folks that were with us on Zoom. I would like to say a very, very special thank you to the 4 corporate sponsors that we have, one of whom you will meet today in the reception. Hopefully everybody will join us for the reception, but Liz Pokar is the director of HOPE, which is a Caribbean navigational company that helps to navigate people to the US. So Liz will be there along with Dr. Mantacone from UHealth International, both of whom are helping to sponsor our reception this afternoon. And also a very kind thank you to GSK and AstraZeneca for their corporate sponsorship. So my closing comment is I love the word serendipity. Serendipity, my kids know, is one of my favorite words. It means in English basically when you stumble upon something or find something that you weren't necessarily looking for, but it has some other connotations. And I think that it's important for us to know that, and this is my own personal comment about having joined the faculty at for which I'm very grateful. So right here in Miami in 1969, a whole bunch of gynecologists, gynecologic oncologists got together in Key Biscayne, which is really not far from here, just across the bay, and came up with the mandate that was given to them by ACOG to actually incept the specialty of gynecologic oncology in 69. And in the actual month and year of my birth, which is January 1970, was the first SGO meeting, which was here in Miami, and the inception of the actual SGO. And one of the most serendipitous things, which is how I want to circle back to what Dr. DiPetrillo said this morning, that those founding fathers, let's say, did was they wrestled away from medical oncology the control of chemotherapy into the specialty. And I think that that's an important thing to remember, because there are no other surgical oncologists in medicine that control their own chemotherapy. And as we see, surgery is becoming lesser important, and the biology of our disease and the therapeutics of our disease is the future of our specialty. So what they did at that time was very, very serendipitous. So a thought back to what you said this morning, Dr. DiPetrillo, and the fact that we are moving away from these big, massive, radical surgeries and really becoming more and more involved in the biology and the genetics of our disease. So thank you all. Thank you for your time. Thank you for your attention. Thank you for coming to Miami. All of us from and on behalf of the faculty, Dr. Schlumbrecht and Dr. Pearson and Dr. Nair, who has just joined us as well at the same time as me, but is away this week, and Dr. Sino, our still humble interim director, but soon to be not interim director. We all thank you for coming to Miami.